Choba is there. But Choba, your face is not visible. Nice to see Dr. Ganesh Tendulkar also, sir. Madam also, Dr.
Good evening, sir.
Good evening.
Good evening, Dr. Choba.
Sir, good evening, sir.
Yeah,
Bala Venkat sir is there.
Bala Venkat is also there.
Sir,
Good evening. Good evening,
Good evening.
everyone,
Good
and
evening.
thanks to Dr. Pankaj for organizing this session. Thank you, Dr. Pankaj. And it's nice to see such excellent stalwarts of private practice today sharing their thoughts. And knowing that India is surviving because of private practitioners, I think it's a great meeting.
Thank you, sir. With all the blessings of all the GC members of National ISA, especially Dr. Bajwa, we could go ahead and start having a series. So let's see. I hope that we can do something great in the next 1 or 2 years. Dr. Diwati is also here. Good evening, sir.
Good evening, sir.
Good
Good
evening,
evening,
Dr.
Diwati, sir.
Good evening,
Good evening. Good evening, Bhimeshwar, sir. Good evening.
Good evening, Bala. Good evening.
Good evening, Dimeshwar sir, Bala Venkat sir, and Diveti sir. Good evening. Pankaj sir.
Good evening, sir.
Ganesh
Good evening.
Prabhu, sir. Good evening.
Good evening.
Hi, Ganesh.
Hello, sir. So, how are you, sir?
See you in one.
In Chennai.
Chennai is far, sir. I mean, right now it is too late. June.
When are we meeting?
June, sir.
Yeah,
June
June
8th.
8th and 9th.
Yeah, it is very far.
Bright. Okay.
Devata sir, shall we start?
Screen ka
Yes, please.
brightness come kar do.
Yeah. Good evening, everyone. And
Good evening.
welcome to a new series of Private Practitioner Forum. We are starting today. It's a very important day today, 30th April 2024. So the idea of having this webinar of the PPF webinar is to know about the various problems, the challenges faced by the practitioners and different sets of the hospitals, from the periphery to the institutions or to the corporate hospitals, from all zones, from all states of the nation. So because our majority of our anesthesiologists are practitioners, almost around, you can say 40-50% of them, maybe more than that, we don't have a data. So the problem may be peculiar according to the region, according to the type of the hospitals, areas. So we will be dwelling upon each of these problems in the coming every month, almost last Tuesday of every month at 6 p.m. So starting with that, the first thing we will be starting with is the West Zone, because Dr. Pankaj is very comfortable with the West Zone, is known to everyone. So it's very easy to arrange the first webinar, and it will be serving as a template for the other webinars to follow for the private practitioner forum. Not just one aspect, it will be a holistic approach towards knowing the problem of practitioners from different angles and different solutions to be deliberated upon in these webinars. And ultimately, the goal is that we want that every practitioner of India should be joining the ISA platform, should be contributing toward ISA. They should be contributing their wholesome dedication.
Sorry, what to say?
I was muted, I think, no?
Yeah, you were muted, Bajwa.
Sorry. I just done finish in 1 minute only, because this is a new series. I already told that it's a new series starting with the private practitioners throughout the country. We will be covering all the zones because the number of practitioners is very high. So it won't be easy to cover in one zone. So we will be going serially, right? This time, first time we will be starting with the West Zone. After that, we will have other zones to follow, where we will discuss all the problems faced by the practitioners, by that and all the just problems, by solutions to those problems, because we will have a very renowned practitioners who have got a lot of experience in their life. With their wisdom, we will be able to search many solutions, whatever been prevalent in our society, the challenges being faced by the practitioners. Moreover, we will be having a special workshop for the practitioners at ISACON this time, starting with the practitioners module, where we will have a special role play during the crisis. Whenever we face crisis in the practice, when we are alone, when the minimal resources, minimal manpower, how to deal with those situations. So that workshop will be there in the ISACON Patna also. So going by this series, first of all, we will be starting with the West Zone. And after that, we will be covering the other zones on every month, on the last Tuesday of every month. And with this, I conclude my address here. But today, all our renowned GC members are there, right? We will be starting with the President's address. And with that address, the best wishes conveyed by the President, he will be conveying to everyone. And after the address is over, we will be starting the real program. So we will be coming one by one. So I request Dr. Devetya sir to give his best wishes to the house.
Yeah, good evening. Good evening. Thank you, Dr. Bajwa. So welcome to this series on of webinars on private practitioners. I must congratulate Dr. Pankaj Gupta on this initiative. He has been very vocal about the problems of practitioners in the governing council, and whenever we speak, he is very passionate about the subject. And I think with very good reason, because practitioners make up a huge component of our society, and they also contribute hugely to the pool of anesthesiologists in this country, and bulk of the anesthetics that are given is by practitioners. Also, there are unique problems that they face. I guess every set of anesthesiologists faces problems, but I think the practitioners, especially the freelancers, are particularly prone to exploitation, poor payments, working conditions, not satisfactory. I think we have a long way to go in getting, to see to it that all our members are satisfied both personally and professionally in their freelance practice. And I think so. It's a great idea to have a series of webinars dedicated to private practitioners, but may I also suggest to Dr. Pankaj and all of you, especially those who are leading the practitioners forum, the private practitioners forum, is, we are going to have talks and discussions by some very young and some very experienced speakers. There will be problems, and we know many of the problems, but there might be unique problems which, will come out in the course of these discussions. So list the problems, list the solutions. I know that in many areas, the practitioners or the local ISA city branches have found some wonderful solutions to some of the problems, especially of fixing charges and, how to enforce working conditions. So many city branches have done a wonderful job, and maybe you can list out these solutions. And at the end of the day, we can come out with something like a white paper on the problems, the actual solutions that some people have used, and the potential solutions that some of us may discuss and in forums and webinars like this. And then we can actually come out with the document. The ISA is already coming out with sort of guidelines for private practitioners, which we'll sort of finalize in due course of time, maybe in the next couple of months. So I think we are working towards private practitioners. This is one more sort of step in that direction. We'll cover all the zones in the next few months, and I congratulate all of you, and I wish this program all the very best. I'm sure there will be a positive result, and it will all be very productive, and it's our responsibility to make it productive and make it count for the future. Yeah. So thank you very much for joining, and we look forward to the sessions, this one and the ones in future. Thank you.
Thank you, sir. Thank you, sir. Thank you very much for your kind words. I request Dr. Ganesh Prabhu to bestow his wishes to us. Dr. Ganesh Prabhu, our Vice President, I unmute yourself. Kindly unmute yourself.
Yes. Am I audible?
Yeah, audible.
Yes, sir. Good evening, President, sir. Good evening, President-elect, Secretary, sir, Treasurer, the other GC members. Good evening, all of you, and also ISA members also. So this is a good initiative of our ISA to start webinars for the upliftment of the private practitioners. Actually, private practitioners are the backbone of our ISA. Nearly 70% of our ISA lies in the rural side. So they are all private practitioners. They face every day lot of challenges regarding the professional aspect as well as legal aspect. So ISA should concentrate, in addition to our academic activities, we should concentrate also on the professional and well-being of our private practitioners. Then only ISA will be flourishing. So these type of webinars will be definitely useful for the upliftment of our private practitioners. So I wish this program should be a very successful one. So I wish all the webinars organized by every zone will be a good initiative for the private practitioners. Wish you good luck. Thank you.
Thank you, Dr. Ganesh Prabhu, sir. I request Dr. Bala Venkat, sir, to kindly give his address to the audience.
Thank you, Dr. Bajwa. And I would want to begin with offering my sincere congratulations and good wishes to all the stalwarts in private practice of this country. Because I think if India in the healthcare sector, if many surgical patients are offered surgery at crucial times, whether it's day or night, it's just because of the private practitioners present across this vast nation and availability of the anesthetist even in the smallest of small villages. So I wish to congratulate you not for doing this work, but doing it under adverse circumstances sometimes and taking up all the stress on yourself to give good results. So this is an excellent initiative, and I thank Dr. Pankaj Gupta for doing this. And I would wish that many of your good work, the world has to know. And I wish that this forum also sets certain timelines, certain yardsticks, certain goals, just not discussion, but just to tell the world how excellent work is being done in this country. So I think we need to keep the target. The next World Congress of Anesthesia is in Morocco. And I wish Dr. Pankaj would take the lead in having maximum number of presentation from Indian subcontinent at doing private work in the World Forum to tell them how good we are and how good we handle our challenges. And many of the new things that we have devised by ourselves, a lot of innovations, we call it as Jugaad. So all this has to be presented in the World Forum. And I think we will make our country proud by doing this. And I also thank the entire Governing Council led by President Divati and Academic Chair Dr. Bhimeshwar and Dr. Bajwa. We have come up with an excellent program, which we will unfold after the next GC meeting in Chennai. This is purely focused on preserving life and preventing pain. And the private practitioners who have been in private sector for a long time and have not been able to update themselves because of their commitments at work. So we are going to open national level simulation based learning in preventing perioperative complications. We have finished the curriculum, a one-day curriculum, and we are going to enter into ISA is going to enter into a memorandum of understanding with simulation centers across the country with a uniform curriculum, and this will unfold very soon. So this would help to bridge the gap and to learn about the new drugs which have come in, and I'm sure this will be yet another step forward in preserving life. Thank you so much for the opportunity and wishing this private practitioner forum and session a very purposeful, impactful one, and eventually resulting in excellent perioperative outcome. Thank you.
Thank you, sir. Now I request Dr. Bhimeshwar, sir, our academic chairman, to say the kind words, sir, for this forum.
Yeah. Thank you, Dr. Bajwa, for giving me this opportunity. Good evening, Mr. President, Vice President, President-elect, the Honorary Secretary, and members of the Governing Council. It is indeed a wonderful initiative by the ISA and the Private Practitioners Forum National Coordinator, Dr. Pankaj Gupta, for taking this issue of private practitioners to the doorstep of everyone. Today's topic, that is issues and problems faced by private practitioners. The speakers and the panelists selected by Dr. Pankaj Gupta are really true in their fields and all, and I'm sure everybody will be benefited by what they'll be conveying to all of us. And then I must also acknowledge here the contribution made by these private practitioners forum, Dr. Virendra Sharma, as well as Dr. Sunil Sethi, who were also instrumental in getting this private practitioners forum. To be remembered by each and everyone. And I think Pankaj breeds private practitioners in his this one. So wherever in the council, everywhere, he just speaks only about private practitioners, and I'm sure this is going very far. So I wish this program all success. Thank you very much.
Thank you, sir. And you are right that the team of this ISA has got a very good practitioners in our present GC, right? So starting from Dr. Sunil Sethi, Dr. Manisha, Dr. Pankaj, and if you go down, there are new entrants also from the private practitioners. And there are many practitioners. I can see Dr. Virendra Sharma, who was the pioneer during that time when these guidelines were formed. So we will give him a chance to speak in the end, sir, because we want him to stay for the entire forum to listen so that he can give his opinion in the end, not now, because we just have a shortage of time. I request Dr. Manoj and then Dr. Rakesh to give the address to the August audience here. Dr. Manoj first.
Thank you, Dr. Bajwa, for giving the opportunity for address here. I am very thankful to ISA National Headquarters, especially President Sir, Secretary Sir, Academic Chair, Mr. Sir, and Dr. Pankaj Gupta is the coordinator of ISA Private Practitioner Forum. So we will also start a private practitioner module at ISA Kon Patna in November. So I request all of you to kindly attend and give information to your PG student for registration of the workshop in private practitioner module. So it is a great initiative by say NHQ. So thank you very much. My best wishes for the private practitioner online webinar series. Thank you.
Thank you, Dr. Manoj. Dr. Rakesh, our editor-in-chief of IJA.
Thank you, Dr. Bajwa. Respected President, ISA National Governing Council and all the ISA members. As we are very well aware that in India, the private practitioners are one of the cornerstone in healthcare delivery. In most of the, even the government health policies that was released a couple of years back and is coming very soon also. Numerous initiatives are there. And even the government is very, very proactive for various public-private partnerships, and there has been great initiatives. I must congratulate Dr. Pankaj Gupta as well as the leadership of ISA PPF, including Dr. Virendra Sharma, Dr. Sunil Sethi, and all who has taken this initiative, because the private practitioners has a major role in the healthcare delivery. Even if you see the statistics, almost 60% of the healthcare delivery is coming from the private sector. So we need to consider those things in the ISA also, and we are taking it forward. I'm sure that this initiative will bring various concerns, but simultaneously we have to bring the solutions also, because the various leadership are there. They know the concerns, and the solutions, amicable solution, will also be coming from this initiative. And I'm sure this is a long way to go, with very good initiative and very active contribution from all the senior leadership of PPF. My best wishes. Thank you so much.
Thank you, Dr. Rakesh. Now, before starting, I just want to share important news. Is the screen visible to everyone?
Yes.
Yeah.
Yes, sir.
So today we are launching the 12th issue of Vapor, our ISA newsletter. And with this, we complete 1 year of our ISA newsletter, which is published monthly, and this covers all the activities of ISA, and various platforms are being introduced in this newsletter. I will just quickly take a tour here. This is our governing council, our editorial board. And we always have this one calendar in this newsletter, so you can plan your conferences, your journey throughout a year. We always publish it in our newsletter, all the conferences and CMEs. And with this now, starting with the ISA PPF webinar, so this will be included here in this page. And this theme of this issue, of the 12th issue, is the patient safety, basically. So you have got the write-ups and essays and opinions from every corner of the country. And more importantly, the Family Benevolent Fund. I think the practitioners should be pushing this Family Benevolent Fund to the extreme now. It is high time that we should be aiming to maximize our membership of this Family Benevolent Fund now. And there are articles and there are opinions. You just go through them. I will just wind up them up quickly. And this is a very important part. We had a record, meeting of the this one delegates at the World Congress at Singapore, and these are all papers, presenters, whosoever presented and whosoever won the award there in the Singapore. This newsletter contains name of each and everyone without missing anyone. I'm not talking about the faculty; it's about the presentation, the paper, the poster, the e-posters. Every name is included in this. So in this newsletter, everyone name we publish. You can go through this thing, and it's a mark of honor to every presenter who took the time, who spent so much to go to Singapore, and at least they have raised the name of their nation there. And this is our invitation for the Patna conference, as Dr. Manoj said. So there are many workshops. The flyers have gone viral to almost every group of ISA. So it's a humble request to register for the conference at earliest. Always tell all our practitioner colleagues as well as PG students, at least to register at the earliest for these things. And these are our partners who are subscribing to the newsletter. Then, very important part is the ISA national level contest, essay contest. We will be releasing the result on the World Environment Day on 5th June. So this flyer has gone to almost every individual in the country. Many entries have come. We have got a very attractive prize, average price of 50,000, 30, 20, and all the practitioners are also invited to this thing. Then these are our branches activities of the ISA city branches, ISA Nagpur city branch. Then all the awards, and then again you go through this Visakhapatnam city branch. All the branches, whosoever has sent a report, their picture, their reports are being published in this newsletter. The Central Zone PG Assembly at Lucknow. Then Loni branch installation, Dr. Divetya were there when the new branch Loni was installed, Maharashtra. Then Junjunu branch, they also, new branch, they did a CME. Malappuram city branch, they did full of activities. And this Guwahati city also, the calls activities performed 21st March. So this newsletter contains all the activities which have been done in the previous month. So ISA Palanpur branch in Gujarat, the calls program details have been published in this newsletter. Trivandrum city branch activities and YuvaCon in Delhi on the 31st March. International Women's Day celebration was done on 10th of this March because all of it returned from Singapore. So it was, I think, attended by many ISA members. And we had a first governing council meeting at first midterm governing council meeting at Raipur, the venue for the 2025 national conference. So this was our team there, governing team. And awards, Dr. Debashi Swan, who was given a award for excellence in healthcare services by the Health Secretary Odisha. And this is our team at World Congress of Anesthesiologists at Singapore. See, we all gathered there. Almost 300 people were there from India, the largest delegate. And now, this is very important for the practitioner. We have started with the practitioner pages. We have got the articles, we have got the views, we have the case reports, difficult scenarios by the practitioner being published now. So this is the first time we are introducing it. So releasing on the day when the webinar is started. So this is the practitioner page. I request all the practitioners, you contribute to the ISA newsletter, you send your case report or whatever the incidents or whatever the opinions you have got, you can always contribute to the ISA newsletter. You can convey. This is a mouthpiece for the practitioners. And we have got a youth zone also, and from the all various young people contributing to this one. And more importantly, the quiz. It will be starting from 2nd. The online quiz will be starting from ISA website on 2nd of May. All the practitioners, PG students, academicians, everybody is welcome to attend to these quiz. Dr. Ramakrishnan Reddy is the program head for these quiz programs. So it is also published in our newsletter also. And we have got art and literary, because these are the award-winning the poems in the World International Women's Day. So everything is published in this thing. And we get interviews also regarding the contribution to the NSCS services in the country. So this is our newsletter. We have highlighted its whatever the publication we have done for the last. I will be circulated tomorrow to all the groups. Now, I request Dr. Pankaj to give us a very brief address so that we start formally for the program after the address. Dr. Pankaj?
Yeah, thank you, dear all national leaders of ISA, for all the wonderful words and great blessings that you have given on this great occasion. I feel in the last 8 years that when Dr. Virendra Sharma and myself were working and communicating with all the city branches, we realized that the work culture, the work condition is very, very different in every city. And we realized that it's very difficult to have one standard formula for every city. So that's why we came out with this idea of having zonal issues being tackled at a national level. So like this time we thought of having the West Zone. On 20th May, we will having it for the South Zone. And in June, we will be having it for the East Zone. The idea is to have all speakers, moderators, everything from the private practitioners in the country, taking care of everything. And because they know the inside story of their city. And believe me, in today's lecture, you will find the journey of a young 7 years, 7 years of in practice as a freelance anesthesiologist. You will come to know how variable the charges are in each city in Rajasthan. You will come to know the surgical safety list and its importance. You will come to know how investments are very important for every freelance or for every anesthesiologist. An alternate source of income once you have, I feel it becomes very easy for you to say no if you are working in uncomfortable circumstances or uncomfortable operation theaters. And of course, the medical legal aspects, I would really want to sensitize all the practitioners that medical legally, many of us are facing problems. So please be very, very careful and see how you can go about being safe. Safe anesthesia practice is what we all want to do in our life. And I feel I would like to hand over the further program to our moderators. That is Dr. Mukesh and Dr. Shivani. They will both be introducing the speakers, and after that we will have a panel discussion, which will again be moderated by Dr. Ganesh Tendulkar and Dr. Teju Chauhan, both are private practitioners from Mumbai. That will again be followed by the question and answer sessions that the audience may have, which again Dr. Mukesh and Dr. Shivani will take care of. And at the end, we can all be there to continue with the panel discussion. Thank you. Thanks a lot, National ISA. We are all there. United, we stand. And I'm sure the private practitioners in the country will be more happier than what I've seen. Me and Virendra have been discussing with so many people, and everywhere we go, we find that the problems are quite huge. So that's why I feel this becomes a very good platform for every city to vent out its problems, discuss its problems, and of course, come out with solutions. Thank you. Thank you once and all for attending this session. I can already see 145 people there. So it's good to have this about of an audience. Thank you. Over to you, Dr. Mukesh and Dr. Shivani.
Dr. Pankaj, at least we should inform the House that this program is also being live streamed on YouTube at ISA NHQ. So I request Mukesh to proceed with, and if Shivani is there, so she can alternate with you also. So start with the introduction of all the panelists, speakers, and moderators. Briefly.
Okay, sir. Okay, sir. Just I'll be sharing my screen. Is my screen visible, sir?
No, not now. At least you have to share it first.
Right.
Mukesh, you can speak also. If the screen is not shared, you can speak also shortly, because there are many speakers and some moderators.
Okay, sir. Okay,
you just speak one by one.
Very good evening to one and all present here. It's a warm welcome to everyone for this webinar conducted by ISA on discussing the problems faced by the private practitioners. I would like to thank Mr. Sukhminder Singh Bajwa, sir, for providing me the opportunity to interact with the esteemed faculties from all over the India through this webinar. Let me introduce myself. I am Dr. Mukesh, currently doing SRship in Government Nagapattinam Medical College in Tamil Nadu. I completed 1 year SRship in Tamil Nadu. Let me introduce my co-screen coordinator, Dr. Shivani from Jammu and Kashmir. She completed MD anesthesia and doing SRship in Government Medical College in Jammu and Kashmir for the past 3 years. She has special interest in pediatric as well as critical care unit. Next, we move upon to the speakers. Our first speaker will be Dr. Sahash Tarwat, sir. He's a private practitioner from Goa. He completed his MBBS, MD, as well as diploma in anesthesia from Goa. He is a gold medalist in Goa Medical College, Department of Anesthesiology in 2017. He is a private practitioner in Goa since 2017. He will be sharing his experience under the title Against the Tide, My 7 Years Private Practice at Goa. And second will be Dr. Dharmesh Gandhi. He's a private practitioner. He's a private practitioner from Maharashtra. He will be talking under No More Silence. He will be sharing how the surgeons are exploiting us. And the third speaker will be Dr. Ashit Vaishnav, sir, from Gujarat. He will be sharing under the topic Who is the Boss, and enlighten us with who WHO surgical safety checklist. And I have my mic to Dr. Shivani to introduce the rest of the speakers. Dr. Shivani.
Good evening, everyone. Good evening, Bajwa sir, and good evening all the members joining the ISA. I'm audible to everyone.
Yeah, Shivani, audible. You can quickly introduce whosoever you want to introduce according to the sequence.
So our next speaker is Dr. Rajendra Sharma, who is a professor and head of anesthesiology in American Institute of Medical Science, Udaipur. He has a 30 years of experience, professional experience, and 80 years of teaching experience. He has a life membership of Anesthesia Critical Care Association. He is the coordinator of ISA PPF Rajasthan State, and he has a president election in Rajasthan Society of Anesthesiology 24-25.
Mukesh, and Shivani, I think we will be introducing the speaker as their turn comes on. Dr. Ganesh sir, is it fine? We will be introducing them as the show progresses.
We've already introduced. No issue. We can start the first talk.
First of all, we should start the program with the first two, three speakers. And then we will keep on introducing them. Yeah, I think.
Not required.
Yeah. Dr. Pankaj, you can start the session.
Yeah, please. I invite the first speaker.
Yes, me.
Okay.
Yeah,
yes, Dr. Sarsh. Please share the screen. Dr. Sarsh.
Yes, sir.
Please share the screen. Yeah, please.
Is it visible, sir?
Perfect, perfect.
Yes. So firstly, before a very good evening to one and all. So before I would start, I would just like to thank Dr. Noel Brito and Dr. Pankaj Gupta for giving me this opportunity. Because I just spoke to Dr. Pankaj after Dr. Noel got me in touch with him, and we spoke for hardly 10 to 12 minutes. And that is when he said maybe my experience would be, worth sharing. So a very big thank you, sir, for giving me this opportunity. Now I'll be speaking on Against the Tide. So, and my 7 years of experience as a private practitioner in Goa. So it's just a small disclaimer. Now I'll be starting the entire buffet of speeches today. So I am just the small 7 years experience because I am 35 years old. There are people who are having 35 years of experience also. So I don't know how much substance I would be having in my conversation, but hopefully, I can set the mood for the entire evening. Now, the reason why did I join anesthesia? So this slide I kept right at the start because I remember during my practice, there was one fine day when I was quite frustrated. So I came home and I was having lunch. That time I mentioned to my wife, I should not have joined anesthesia. Maybe I should have joined some surgical branch or something like that. And that is when she told me, do you know why you joined anesthesia? I said, no, I don't know. Because that is the only subject you were getting that time. So That is, I had no other option. So I joined anesthesia because I got anesthesia. Now, having said that, I would not say it's a bad branch, because whatever I have done and achieved so far is because what I have learned in this entire stream. And that is when I remember that I always spoke about this to my friends as well, that Ratan Tata had mentioned, do not waste time in taking the right decision. So I did not make any this thing. I took the decision of joining anesthesia, and now I'm working every day, every year by this thing, to trying to, you know, make it a right decision for me. So this is when I joined anesthesia in Goa Medical College as diploma anesthesia, and subsequently completed MD anesthesia from Goa Medical College. Now, after that, I served as a senior resident, and then the question came whether should I continue in government setup or in private practice. So I would just want to highlight what are the various benefits in either sector. So in a government sector, there is definite job security. After you get a permanent post, you'll be working there for the rest of your life. There is easy assistance available in a government setup. You will have the consultants, you have the senior residents, you have the junior residents. So you have someone who will come before you to the OT table. You know, the junior resident will be there. They will prepare all the drugs. They will go do a PAC. So that assistance is easily available. Next point, in government setup, they will have regular classes. So you are constantly in touch with academics. See, over time, I agree that we might tend to forget a few aspects. So when you're doing it again and again, every year the same classes will be repeated, so it gets drilled in your head right at the means every year it has been done. Secondly, dignity. Like today, if I go in a function and I ask, they ask me, what do you do? I say I'm a freelancing anesthetist. Then they ask which hospital. So I cannot pinpoint one particular hospital as such. But in a government setup, you are usually working in a tertiary care center, so everyone knows, like, you are working in Goa Medical College. Fine, that is good. So the next point is they will have one of the best setups. Like, easily it will be available. They'll have video laryngoscopes. They have the best of setups. So there is no drawback in that. And finally, this is one point which I would mention, that they get paid vacations. So even in Goa, they'll have vacations around Diwali time, and they have the summer vacation. So there is 1 month or 15 days of paid vacation where they can have some quality family time. The disadvantages of government setup is hierarchy. Now it depends on how well you are having interpersonal relationship within your department. So those department politics may come in eventually. So that is the one thing which may hamper your progress. And secondly, fixed income. So unless you get a promotion, your income remains at that level for a certain number of years. Coming to the private sector, it is more like you are your own boss to some extent. That's what I would mention, to some extent. So you have the liberty of taking decision. You can decide whether you want to take this case, you don't want to take this case. So that liberty is there to you. You can decide whether you want to go home right now. Means if there is, you can say no to a case at some time. Then secondly, the other big benefit is you will be paid according to your work. Now, how much it is you are paid, that is different, but you will do one case, you get paid for one case. You do another case, you get paid for that case. So you are paid according to your work. Secondly, you can always make time for alternate ventures. If you have any other business prospects, you can always have alternate time for that. You can have some time for your personal hobbies also. So which may not be that much in case of government setup, where they are giving you non-practicing allowance. So you may not be able to have other trade formats. The disadvantages of private sector, I would enumerate, that is, it is entirely a dependent branch because we depend on various factors. I will enumerate them later on. In a private sector, unlike the government sector, you are one-man army. So you will be the one who will reach prior to the surgeon. You have to see the patients, PACs. You only have to set up the trolley. You only have to check the suction. You have to check whether oxygen supply is there. You have to check the circuit of the patient, of the machine. So you are the only person who is responsible for whatever happens to the patient during that surgery. It is like a daily wage worker. So if you decide to go on a holiday, you will not be paid for during that time. So there is no income coming during that time. Secondly, very early in your career, when you don't have fixed attachments, when you take a holiday, even to restart work after joining back, that takes some time. I would say at least it would take me at least 1 week. I would not have work after that. If you take a holiday of 5 days, after that for a week, because what happens, usually the conversation during the OT is, during the case, are you available for the next case, that is tomorrow? If that is not there, then they will, if you are available, you get that case. Otherwise, it wouldn't be coming to you. Secondly, in a private sector, considering the setup, it would not be, unless the anesthetist is a part in the hospital ownership. Most of the hospitals which are having anesthetist as ownership would have a very good setup. But in many places, we tend to compromise on the limited, we have a limited setup. We don't have the best of everything and access to other this thing. So most of the times it depends on whether it is available with us. So that is what you end up, you tend to work in a limited setup. Then there is an uncertainty of work. So if there is any mistake, if there is a mistake, you may not get called later on for the by the same surgeon. Whereas in case of a government setup, your mistakes, you have some assistant over there. So there will be someone will be covering up for you. Over here, that is not there. So there is uncertainty. So considering weighing these two benefits, I decided to go ahead for private practice. Now, initially, when I started, I had no idea whom to approach. So I went around Margao, I approached all hospital owners. So that is hospitals which are owned by non-surgical doctors. So there'll be physicians, there'll be other, businessmen who would own hospitals. I met them. Then I realized I'm still not getting cases. So I went around and met surgeons in their OPDs. So that is when they told me that they would be willing to call me. They assessed, what I would do and all that. And then they told me that you can go and meet the OT brothers. So there will be OT staff who's there. So they are the ones who would, schedule the surgeries, and they inform the anesthetist. So I went and met the OT brothers. And that is when I went and met the fellow anesthetists who are working along with me. So that maybe I would have, approached them earlier. That would have been beneficial for me. But I met them later on. After that, I had these few rules which I had set to myself. So I decided I would give myself 3 years to decide whether I want to continue in private sector or no. Because in the first month, honestly, on the 27th day, I started on 1st of November. On 27th of November was my first call. That is after 27 days of sitting at home after meeting everyone. So I had decided I would work for 3 years and see how it is going on, and then accordingly decide whether I would want to continue in private sector or I would have to consider shifting to government setup. So that was I was aware that the start would be slow and it would be a gradual start. At this juncture, I would like to mention that I got a lot of assistance after meeting from my anesthetist, my fellow anesthetist. They all helped me. Quite a lot of them helped me. So I ended up speaking to anesthetists who are working in the government setup. I would discuss cases with them. They would guide me. I would discuss cases with one particular senior resident who were there. So there is that bond between a senior resident and a junior resident during our residency. So then she was always there to guide me throughout my career so far. Then even when I'm working in and around our area, that time I had anesthetists, the senior anesthetists who were there, who realized that maybe I can be of some help. So they would always call me whenever they needed any form of assistance. So that was another very beneficial thing. One senior anesthetist, when he even retired, he had given some of his commitments to me. So I am very grateful to the anesthetists who have helped me. So he retired at the age of 65. That is when some of his commitments had come to me. At the same time, there were other anesthetists who did discourage, but that is there, and it is human nature, I believe, that we have the territorial behavior. So when I approached them, they said like, no, it is much better to work in a government setup and all those. So discouragement was there. But having said this, see, I have colleagues who are my friends who are done surgery, and they are also there. I felt it was easier for us to establish or to reach a decent level of work practice as compared to a surgeon. For a surgeon, I believe it would have taken a longer time. So for me to have a decent amount of work, I consider that 6 months were enough for me that time. Whereas for a surgeon, to convert a patient from the OPD to an OT table, that is a difficult time. I think they require much longer. That is what from my fellow surgeons, that is what I had realized. Then coming to the point where another difference which I noticed, when we were working in a government setup, we would have a physician who would assess the patient. There were all references sent. But when you come into private practice, quite on many occasions, you are the perioperative physician. So you can decide what has to be done for the patient. So then slowly as I was working, the surgeons would refer a few patients for PACs whenever they thought that it would be a difficult case. So those patients you have to assess from your perspective as a perioperative physician. Having said that, the major drawback which was there is management of time. Now, if you are considering PAC and then you are the perioperative physician, if you have back-to-back cases, it becomes difficult for you to go and assess the patient again if you are not in the same working place, if you're not working in the same hospital. So scheduling the cases, that was difficult. So I really didn't know, and I still don't know actually, means how much time should we keep between the two cases. So that is not working out for me so far, because many a times taking the case, or no matter how difficult the case, that is not the difficult part. Reaching the hospital becomes a difficult part, because travel time is never considered by us. So many times we'll be stuck in traffic. So that is another thing. Management of time becomes a major drawback as far as private practice is concerned. Time will be more utilized when you're working towards a peripheral setup. Now, when in Margao, in Goa at least, we are not having issues. So the furthest I travel is around 35 kilometers. It takes me around 40 minutes to 45 minutes to reach 35 kilometers, which is unlike any other metropolitan cities. So having said that, safety standards in a peripheral setup, there we are having limited setup. So initially, when I started, we were working on Boyle's machine. We didn't have means there was no central oxygen. We would have oxygen cylinders which were there. Then drugs, availability of drugs. I remember carrying few drugs along with me. So that is the major issue, that safety is compromised when working in a peripheral setup. Another major issue in a peripheral setup is you would not have assistance in case there is something going wrong. For the assistance to come, you have to anticipate or wait for 30 minutes for them to come from the nearing city. So that is another thing which is a major concern when we are working in a peripheral setup. But having said that, I still owe a lot to the peripheral setup, where I initially got most of my cases, and I guess all beginners, we start from the peripheral setup. Even when I'd approached hospitals in Margao city, in the city area, that time we were told that we already have fixed anesthetist, you would have to start approaching from the peripheral setup. So I still attend my periphery calls, and I can proudly say that my group of anesthetists, now all our peripheral setups have a workstation. Everyone has an LMA, all have functional circuits, and all have good supply of oxygen. So that is what we have initiated from our side. So whatever basic requirements, so safety standards are there. Another main concern is defibs. All hospitals have a defibrillator. Now, the other drawback of private practice is we do not have much academic growth, less academic growth. I don't know, whenever I speak to my consultants from the government setup, they always mention, means whenever we discuss a interesting case, they will say that you note it down, you keep documenting these cases, but it does not really happen to us. And I agree that I have not done it. So I'm not, we don't have any publications. So academic growth is not there. I try to see that whenever we are in a meeting, so we try to discuss some academics, but then that is one thing where I feel the private practitioners are lacking in. Then coming to payments, now payments is something, as a 7-year-old anesthetist, I would not have focused much on payments so far. I don't know now. I don't know whether this is a right approach or wrong approach. I'm open for criticism, but I believe that currently in a scenario, in my current condition, I feel that having more volume of cases would have been more priority as compared to having premium of payment. This is my approach, what I feel. Payments in our state depends on various factors. Patients can be affording, non-affording. In peripheral setup, payment is different as compared to city setup, payment is different. Patients who are having insurance, it is different. Patients who are having government schemes, that is different. So that is the thing. Another point is keeping track of payments for us, because if you are having around 50 to 60 cases, to keep track of payments, we don't get payments at the end of the month. So keeping track of the payments is an issue. Secondly, what I believe is, as an anesthetist, we have a ceiling effect. We have 24 hours in a day, out of which some amount you tend to sleep at home. So there is a certain number of cases which you can do. And in that certain number of cases, that is one highest amount which you can earn. So that ceiling effect, I think, is there in anesthesia, which is not there in so far in other branches, where they can keep working and they tend to have more income. Now, having said this, I would just highlight a few mantras or some rules which I have kept for myself. So these are not my ideologies. This is what has been shared to me by my fellow colleagues, my senior surgeons, my senior anesthetists. So one such surgeon had once mentioned to me, practice today like how you would want to practice 15 to 20 years from now. Now, by this, he does not mean like, how much hours I want to work, but it is basically the principles on which I would want to work. Like some anesthetists in my city, I have seen, they are more comfortable doing regional cases. So they have decided that they will opt for regional cases. Some anesthetists are willing to take high risk cases. Some anesthetists are willing to take, not willing to take high risk. They want to have a safe approach. So that is what I believe what I am trying to say is we should practice something what you want to practice for the next 15 to 20 years. Again, I will repeat that I am not saying about duration of work, because when you are younger, you can move around, you can do a lot of work. I believe you can do that. Later on, slowly, you would want to cut down on that. But what I'm saying is the quality of work. So that is what I'm trying to insist, that you may not want to take high risk cases right at this time. So you can opt for that kind of practice also. Second thing I want to mention, which again has been told to me by a fellow surgeon, the anesthetist, you have to judge how frequently you want to take high risk cases. Eventually, as you are working, you will tend to have high risk cases. But always remember that adverse effects will come, adverse outcomes will always be there. So whenever you are taking high risk cases, go with adequate preparation. Always feel free to ask help from other anesthetists. Having a mishap very early in our career can be detrimental, and I have seen that happening to a few colleagues of mine. So when they tend to take a high risk case, you have to make sure that you are adequately prepared and try to avoid a mishap during a case very early in your career. It is like a simple norm. Like when a newcomer comes and gives spinal and the spinal fails, it is a technique which is wrong. But when a senior anesthetist comes and gives spinal, many a times the surgeon will say maybe the drug is not acting or the badge is not acting. So that is what I am trying to say, that very early in your career, try to avoid having a mishap in your career. So that is one way. Secondly, I'm not saying you should run away from high risk cases. If you are confident enough, you should of course opt for those cases, because once in a while the surgeon has to know that you are able to take those cases. So that is when you have to go adequately prepared, take a fellow anesthetist and go ahead. If there is any side effect of any particular drug which is mentioned in the book, never think that it will not happen. Always it will happen. If it has not happened to you, it is your good luck. Otherwise, you have not done enough cases. So that is what another point which we have to maintain. Another mantra which I believe is invest in your profession. So initially I had started by borrowing an anesthesia kit. I had my own Bain circuit. I had my own laryngoscope. I had a few tubes. I had airways. Then later on I tried and went ahead and purchased my own video laryngoscope. That is when I tried, I really felt like, it is of a great advantage. Now I even own a peripheral nerve stimulator. I have my own set of PNS needles. And of late, on the last 6 months, along with an ENT surgeon, in collaboration with him, both of us have invested in a flexible bronchoscope. So he has been a very close friend and he has given me the liberty to use it as and when I need it for anticipated difficult airways. Another thing what I want to mention at this time is we should not try to belittle or undervalue our subject. So many times it will be like, "Arey, tu kya karega case mein? Case mein jaake baithega, spinal dega, baithega wahan pe." I don't think that approach we should keep, even if it's a general anesthesia case. I think, and secondly, we should not demonize the surgeon. Many a times the surgeons are more than happy to, discuss the case with us. So you should try to speak to the surgeon, explain to them what risk factors you are anticipating. Many a times you will get the surgeon asking you, should we opt for open or laparoscopic? So you try to, rationalize with them at that time. So don't belittle or undervalue our subject. It has to be there. And the last point is what is told to me by a consultant recently. Over the last 1 year, I've been trying to have a sense of gratitude to your patient. See, the patient comes to you with a sense, means they are giving, and you have not met the patient. They have met the surgeon. Out of the surgeon has called you. So the patient has given his entire life in your hands during the time of surgery. So at the end of it, I feel we should have a sense of gratitude towards the patient. And that is what, can help us have safe anesthesia. I remember one of my consultant mentioning, do to the patient what you would do to your mother. So that is what I'm trying to say. If you don't want to do it to your mother, you would not want to do it to the patient. So that sense of gratitude has to always be there towards the patient. So that is how, maybe if this is what I'm trying to follow so far. Whether it is right or wrong, I'm still yet to decide. I still don't know, but I'm open for criticism in whichever aspect I've mentioned so far. This is how I had gone about my practice. Now, other ventures which I did try, but I was not successful, is evening OPDs. I decided I would go and sit in an OPD for general practice. But then eventually I decided what would happen was, if I have a call and there was no patient, I didn't have I did not have the courage, I would say, to say no to the call and wait for a patient to come in the OPD. So that is when I discontinued OPD. I did attempt it, but I didn't succeed in it. So that is when I like a stop loss, I stopped it currently and I have discontinued evening OPD. So I have converted that into a blood collection center. So that is what I have been trying to do. A blood collection center is there, and I have been in collaboration with the laboratory. So that is another venture which of mine. I did make an attempt, a group of friends, like-minded people. We did make an attempt to have group practice, but that again was a failure. We were unable to initiate it only. So that fell apart. So our idea came from the group Exxon from Hyderabad, but we tried to replicate that, but we had our own pitfalls and that didn't succeed. So these were the other ventures which I did try to explore. Now, with that, I think that I would conclude my talk. Thank you very much. So I hope yes, sir.
Dr. Sir, forward. That was one of the best talks I could have ever imagined from anyone who is 7 years in practice. It was a fantastic talk, right from the heart. And I feel the messages, take-home messages were excellent, just too excellent. I feel it's very happy that as a junior, we were welcomed well in our city. I feel it is very important for all of us to welcome our juniors. There is always a waiting period. Give your first 2 to 3 years and let over 3 years, you do get exploited. You do have a lot of troubles, but the patience in you will increase, will eventually make you a successful private practitioner. Doing 2 to 3 cases in a day is much better than, as a private practitioner, rather than working for 12 hours, as you find in corporates these days. And I feel once you are senior enough, you can even charge adequately. It takes some time, but once you are settled in practice, you can decide your own charges. Documentation is an issue, but the great thing is Dr. Rakesh Garg is already trying to do something for the private practitioner, and very soon we will have some sort of guidance from him about it. I feel you mentioned about going for cases in time. I always prefer go 15 minutes before the first case in the day, so that you can confirm what is there in the OTA and confirm what is not. And this, unfortunately, as freelance practitioners, we have to do it because it's a one-man show. And I feel group practice is going to be there in the near future, and all of us should think about it. I feel that was really a great talk. I'll now invite the next speaker, that is Dr. Dharmesh Gandhi.
Dr. Pankaj, before going to next speaker, I should congratulate Dr. Saharsh. He's the opening batsman for the PPF, and he has done just like IPL. And I think we should all clap for him before going forward.
Definitely. Thank you very much.
I think 90% of the slides he presented, he stole from my slideshow actually. That's what I used to speak. Anyway, thank you, sir. Thank you, Dr. Saharsh. Please go ahead. Dr. Pankaj, please go ahead.
Yeah, thank you. Dr. Dharmesh Gandhi from Maharashtra. He'll be talking on no more silence, facing exploitation by surgeons. What next? I mean, all of us, as I said, first 1 or 2 years, we do get exploited, and then we all decide what we want to do further in life. Some continue with private practice, some go to institutes, some form a group, some go into pain clinic. Believe me, the incidence of private anesthesiologists going into intensivist is almost 47%. And about 17% of anesthesiologists are switching to pain. So I feel we will learn something more from Dr. Dharmesh Gandhi about what he feels is good and what he has done in his career as a practitioner. So over to Dr. Dharmesh Gandhi, please.
Thank you, sir. Good evening, everybody. Good evening, my teachers, seniors, my friends, colleagues. Am I audible?
Yes, perfect.
Hello.
Yeah, you can go ahead.
Thank you so much. I come from a small annex of Pune. It's known as Pimpri Chinchwad area, PCMC area. And like everybody has experienced this exploitation by surgeons in a way. So something different you can do. That's what I'm trying to tell today. So as you can see, this is the slide which shows how much an anesthesiologist earns, but this is from USA. It's not from India. So you can see, well, we are way above the oncologists, the plastic surgeons, and even the physicians. But in India, sadly, it's totally different. On an average anesthesiologist must be earning most probably somewhere what a general practitioner also earns. So in spite of running continuously hard throughout the day and with our stressful life, we generally are very much always at stress, the maximum stress we face. At the end of the day, somewhere we finally what matters is that we should have a good family life, we should have earn a good amount of money, and should have have a good practice satisfaction. So my entire lecture, what I'm going to do is I'm going to divide into three parts. First is the problems which are faced by freelance anesthesiologists. Now this work has been already, Dr. Search has already briefed you a lot. Second is the rational solutions to these problems, and third is my accomplishment, what I have done. So the challenges which are faced by freelance anesthesiologists. The first thing is the dependent practice. Well, perhaps it's a bitter truth, and which we must all accept, that our practice is definitely dependent on the surgeons, the hospital owners, or even maybe the hospital owners which are owned by BMS people or even the non-medical people. Here we don't have any like friends, college mates, or anybody, and ultimately we are on our own. It's like freelancer is highly, we should not feel that we are indispensable. You can be replaced anytime. However hard we try to deny the truth, but definitely our branch is dependent, someone like pathology or radiology, etc. Definitely the experience matters, but it's only partial. So we don't have a choice, basically, when to practice, how to practice. We called late nights, early mornings, and then we definitely need to go. We are healthy. I mean, our health is compromised. There are a lot of issues. We don't have any social life, and because of all this, I mean, generally we are in a state of frustration. So even after, and sometimes there are free days also as well, where we don't get any cases, and then a negative stream of thoughts they starts over with us. As the age, and now the practice is like a capnography graph, you can say. Initially, you have a very good practice, you go, you're very high on the practice, then there's a plateau, and after some time, the practice comes down. This is what happens with most of the anesthetists in India. So basically, as the age advances, the number of attachment reduces, and we expect a bit of leniency from the surgeons, which generally is considered a liability by them. And as the seniors, we fail to go and meet the new young people, the young surgeons, and that's why we become more rigid. Apparently, we are labeled as more expensive, and that's how basically our downfall begins. The one more problem in our practice is at least in Maharashtra, we have something called a BMS MD anesthesia. This is a new group of virus. You can see they are practicing anesthesia everywhere. After BMS, they are taking a postgraduate course in anesthesia. They are practicing all over, especially in the rural areas of Maharashtra. And they are practicing in all the compromised situations. There's no standardization. And along with that, they're charging minimal. And that's why many times, and especially in the periphery, they have an upper hand over our MBBS MD anesthesia also. So this is one big problem, especially in Maharashtra right now. I don't know about the other states. Next is everybody has unpaid receipts from many hospitals. We have to do a lot of free cases. The discount cases are there. Then as the age advances, we have our own ailments, and all these things ultimately actually drives us down in our own practices. Many times most of the times we work in compromised resources. We are there and we cannot complain to the hospital or hospital owners about these things. Depending on their mood and their behavior, we have to compromise. So that's it. So ultimately, this is one very important slide which I would like to mention. I will discuss all the problems about anesthesia. Now, if you think with an open mind, basically we are actually a bunch of lazy people. That's what I feel personally as an anesthesiologist. Now, why that? Because we have a lot of inertia with us. As in a way, we are getting easy money just from doing the cases. We are nowhere involved in the OPDs, the struggle to convince the patient, the bargaining of the patient, and all the tantrums what the hospital owners and the surgeons they face. So this is a big problem. And most of our freelance anesthesiologists, we are unaware of the managerial and the administrative issues what the hospital owner faces. And given the scenario in the coming recent future, with whatever BJP government is proposing, I think so they are trying to take down the charges of the corporate and the private practitioners to the CGHS level. So we are going to be suffering a lot because of this. Anyway, generally speaking, what we do generally is we are in generally a professional euphoria type, what you can say, and we just keep on patting our own backs. We have done a very beautiful job today and all. But ultimately, you should remember that the reality is that we are not invincible. So what are the rational solutions for this? The rational solutions are that you basically don't keep all your eggs in one basket. That's a simple solution. We can do a lot of things into medical practice itself, apart from the non-medical things also. So what all anesthesiologists can do in the medical field itself? Like everybody knows, we can start a pain clinic, we can work in ICU, but pain clinics and all basically there's a long learning curve in the pain right now. Even after once you once you've started your freelance practice, it's actually difficult to again go take out time to learn things, to go for conferences. And there's a learning curve, and then when who will send the patients to us is a big problem. So many anesthetists they part-time practice in the ICU also. It's a good thing because it helps them in the private practice also. But then ultimately it's not that easy and not that profitable what a freelancer anesthetist expects. So what you can do is you can have an evening OPD. So most of us actually have a lot of free time in the evening. So we can go there and we should forget that it belittles us and all. This is not at my level and all. And we should start an evening OPD. We can start a hospital of our own, multi-bed hospital. It can be a nursing home, a tertiary care, or whatever. Next, you can invest with a group of people. You can start a pathology lab or a radiology clinic, but this has to be in a group, of course. You cannot do it on your own. It's dependent again on pathologists and the radiological people also. You can go to overseas. You can have a job. That's the easiest way out from here. Go back. Many people, they fly out from India, or you can join a government or a private medical college as a teacher. So this is one thing which I wanted to tell. You can actually involve yourself in somewhere in the pharmacy. You can have a pharma shop of your own somewhere in any of the hospitals, a pharma distributor, pharma company. Now here I wanted to put a very important point. ISA Pharmaceutical. As a group, actually, we can have our own pharmaceutical company, which can be taken out by ISA. Suppose anesthetist is using 1,000 rupees drugs per day. Out of this 1,000 rupees drug per day, 500 rupees will go to the pharma company. So if you calculate this way, this money can come back to us if we all come together, start our own pharmaceutical company. But this has to be done at the level, big level, maybe at the state level or at a national level. Then only it is possible. And it is actually difficult to implement, but the investment what we'll be doing in this will be very less comparatively. Returns will be definitely better and n number of times what we cannot think of also right now. We can also have a mediclaim company which through ISA, which can like something like Star or Bajaj Alliance and all. It's not a very easy job, very easy to talk about. Still, we can think, at least start thinking about it. Regarding the PG students, I would definitely like them to know what they should be doing is that they should be spending a little bit of time on understanding the financial planning of life, the management issues of hospitals, and all these managerial things, administrative problems. They should be actually taught in the PG time only. What are problems freelancer is facing, what a hospital owner is facing. Nobody teaches all these administrative problems in any of the curriculum, which we come to know by experience only. So this has to be taught to the PG students. Now, finally, what I did. Well, my inspiration came from two people. One is when I met an anesthetist who was just running around here and there, and one day, fine day, because of hectic work, he just slept on a two-wheeler. He got his leg broken, and then I realized nobody was there to call him. Second one is the Ozone Hospital, which is there in Akola, place in Maharashtra. And I'm really very proud that I have friends like this. They are a group of anesthesiologists who have established and are running their own hospital, a big hospital, tertiary care hospital, 200-bed hospital in Akola. So I was thinking even I can do something like this. So first I started with a chain of blood banks. There's a big story behind it, which this is not the right forum to tell how I started it. Right now, I mean, we started with the first blood bank in Pune by the name of PSI Blood Bank in Pune. After that, we had in Pimpri-Chinchwad area. Then after that, in Mumbai. Then we have right now, presently, we are having 18 blood banks. That's all over India, in Gujarat, in Delhi, in South. And along with that, we have almost 48 blood storage centers all over the India. At the same time, now we are 10 years back, I started a group hospital by the name of Sterling Hospital in Pune. We had 22 doctors, all super consultants and consultants over there. We are doing, then after the last 3 years, I have started one more hospital by the name Imperial Hospital. We are doing almost 250 cases per day in both these hospitals. We have total 5 anesthesiologists over here. So basically, we ensure that each of us gets at least 50 cases per day. That was the idea behind it. So rest assured, whatever I do in freelance anesthesia, even if there is a dry day, I don't get any cases, I'm sure I'm going to get some cases in my own hospitals. Secondly, I tried to open, we had a pathology lab over here, but somehow it didn't turn out very well, and then we had to shut it down. Along with my freelance practice, whatever I'm doing a lot of pediatric anesthesia in PCMC area. And so I would like to conclude my talk by saying that busy anesthesiologist, actually, it's actually a very vulnerable thing. and he doesn't have the time and the inclination to think about what he can do laterally. So it's better that you do only less amount of cases, and then you start thinking laterally to do something else in medical practice. Non-medical thing is not in my the lecture. So that's it. Thank you,
you,
sir.
Dr. Dharmesh.
Hard
That
work
was
cannot
really
replace talent. Hard work is talent.
that was really a stimulating thought. I mean, with so many options that an anesthesiologist can have, especially if you're in a private practice. Even I believe in this: do less work, do good work, charge adequately, be happy, and look for parallel source of income. When you have a parallel source of income, you can easily say no to any surgeon or hospital where you're not comfortable working with. You said about dependency of our branch. I feel today it has become an interdependent branch. In the initial few years, I agree, you go to every Tom, Dick and Harry. But over time, you learn to filter a surgeon. I call it the law of filtration of surgeons. And then the surgeon waits for you and keeps his cases according to when you are free. This BMS anesthesia, I feel, is a new thing which when I came to know just today. So I feel definitely at state level of ISA, we will discuss something about it. And I feel the various options that you have put forward should be an eye-opener for many of us, especially in those cities where you find anesthesiologists being exploited a lot. There are various options. Please look into it. One very important option which many of us follow is our investments. We are having another talk on it after the next two talks. So I feel you mentioned something about investments. I was in Indore for a conference and I was surprised to see that the head of department was discussing investment with his residents. And now that the residents have a good amount of salary, they already started investing in the first and second year of being residents. So this was another new thing which I learned very recently. Thank you, Dr. Dharmesh. That was a wonderful talk. We will go to the next talk now, Dr. Asit Vaishnav. He needs no introduction to the whole country. He is going to talk on who is the boss. Whose surgical safety checklist relevance in today's practice? I feel it is a very important thing for each one of us in freelance practice, especially to follow this WHO checklist. Small things have been inculcated, which makes anesthesia practice very safe. Over to you, Dr. Asit Vaishnav, sir. You can start sharing your screen, sir.
Good evening. Yes, the title is Who is the Boss? The answer is there. WHO is the boss. WHO surgical safety checklist and its relevance in today's anesthesia practice. It's not going. So my talk is basically theoretical one. And the resources are from WHO site itself. So there are three problems in surgical safety. It is not recognized as a public health issue. We have many public health issues: infectious disease, heart disease, lifestyle diseases, but surgical diseases are not recognized as public health issue. There is lack of data on surgeries and outcome. And most important thing is that failure to use existing safety know-how. Janami aham nacha me pravrutti. Problems. So it is estimated in 2008, it was estimated that there are 234 million operations a year. And out of that, 3 to 16% complications, so 7 million complications are disabling complications, and maybe around 1 million deaths worldwide every year. So 50%, and it was thought that 50% of these were preventable. The estimate is this number is more than the combined death due to HIV, malaria, and TB combined. And the causes are preventable most of the time. Incorrect patient, incorrect site, airway aspiration problems, anesthesia complications, underpreparedness, lack of instrument check and monitoring, blood loss, unpreparedness for blood loss, and unknown allergies. Problem 2, lack of data on surgery and outcome. Collection of data improves improvement in maternal mortality dependent upon our routine surveillance and collection of data. So surveillance is lacking for surgical care. Failure to use existing safety know-how. This is very important. High rate of preventable surgical complication site infection result from inconsistent timing of antibiotic prophylaxis. And they would remember on table, oh, antibiotic diya kya? Have you given antibiotic? Has anybody started preparing for it? So these are the things. Anesthetic complications are 10 to 1,000 times higher in countries that do not adhere to monitoring standards. We had a experience from past that when we did not have monitoring standards, the complication rate was very high. Wrong patient, wrong site operation persists despite high publicity of such event. Reality checks. Currently, most hospitals do most of the right things in most of the patients at most of the times. And such checklist helps to do it in all the right thing in all patients at all the times. So WHO took initiative, save surgery, save lives. In January 2007, WHO launched a project initiative Save Surgery, Save Lives aimed at improving safety of surgical care globally, identifying minimum standards of surgical care that can be universally applied across countries and settings. The checklist was born out of work by WHO from 2006 to 2008, improving the safety of surgeries globally. The checklist draws heavily on the safety checklist and use of checklist similar to high-risk industries such as aviation industry. Aviation industry is having very much traffic, and if you see the numbers, tremendously high volume of passengers are being carried all over the world, but it is again a safe industry because of checklists and cockpit drills. It's a teamwork. So WHO in 2006 to 2008 prepared a surgical safety checklist. This is the standard checklist they have advised. So before induction of anesthesia, before skin incision, before patient leaving on the surgical OT. It is also known as sign in, time out, and sign out. So what are these components? Let us detail. It was developed after extensive consultation with a team of international experts in surgery, anesthesia, nursing, and patient safety, aiming to decrease errors and adverse events and increasing teamwork and communication in surgery. Advantage of this checklist is it is customizable, supported by evidence, evaluated in diverse settings around the world, promotes adherence to established safety practices, minimal resources required to implement a far-reaching safety interventions. So this is the checklist. So before induction anesthesia, you are supposed to do certain things. Before incision of skin incision, you are supposed to do some things. And before patient leaves the operation theater, you are supposed to check few things. These are 19 lists, 19 checklists, 19 items on the checklist. So before incision, has the patient confirmed his or her identity, site, procedure, and consent? It is with anesthetist and nurse. The team onus is on anesthetist and nurse before induction of anesthesia. Has the patient confirmed his identity? Is the site marked? Is the anesthesia machine and medication is checked completely? Is the pulse oximeter on the patient and functioning? WHO has relied on pulse oximeter only. It is in from 2008. Nowadays, we recommend some other things. We have adapted more things. Well, I will come to that later on. But so here, pulse oximeter signifies the anesthesia monitors and anesthesia machines. Does the patient have a non-allergy? Do you expect difficult airway or respiration risk? Risk of more than 500 ml blood loss, that is 7 ml per kg in children. If you have anticipated all these things, check it before induction of anesthesia. Now, desired updation to this anesthesia checklist. In preparation for anesthesia induction, have following items been checked or not, or they are functioning properly? Anesthesia machine, suction machine, cardiac monitors and electrodes, pulse oximeter and probes, patient-specific size probes, BP apparatus, NIBP monitor, and appropriate size cuffs, airway management tools, laryngoscopes, endotracheal tubes, eye gels, whatever, difficult intubation kits, anesthesia medication, suction, oxygen, capnography, ambu bag, defibrillator. In simple words, our checklist of RSI, rapid sequence intubation, so suction, oxygen, airway, instruments, pharmacy, machine, and electrical machines. So that is adaptation or from anesthesia side that we should also check these things before induction of anesthesia. The second part is timeout, that is known as timeout, and it is before the incision. It is to be confirmed with a nurse, anesthetist, and surgeon. Confirm all team members have introduced themselves by name and role. We private practitioners find it amusing these things, but in a corporate place or where multidisciplinary hospital, there may be team of surgeons, there team of anesthesiologists, and there will be team of nurses, which may get changed day by day. And many a times we do not know who is there inside OT. So it is a good approach to identify each person and identify each person's role. There is a separate topic of team management in WHO safe list, safe surgery checklist also. Confirm all team members have introduced themselves by name and role. Confirm the patient's name, procedure, and where the incision will be made. Again, confirm with surgeon. Has antibiotic prophylaxis been given within last 60 minutes? This is the area which is not followed by many people, and WHO has shown it. I'll take in next slide. Anticipated critical events. To surgeon, what are the critical or non-critical routine steps? How long will case take? And what is the anticipated blood loss? To the anesthetist, are there any patient-specific concerns? To nursing team, has sterility been confirmed, including indicators? Are there equipment issues or any concerns? Is essential imaging displayed in a relevant case? And before leaves patient's operating room, there is known as sign out. Nurse verbally confirms the nature of procedure which has been done. Completion of instrument, sponge, and needle counts. Very important step in surgical safety. Specimen labeling. Read specimen label aloud, including patient name. Whether there are any equipment problems to be addressed. And to surgeon, anesthetist, and nurse, what are the key concerns for recovery and management of this patient? So this surgical safety checklist has stressed upon teamwork. Nothing is new. We knew everything. Everything in the list is taught to each member, anesthesiologists, surgeons, nurses, and theatre professionals in their basic curriculum, basic course curriculum. This is an integrated team approach to implement what had been learned at medical schools. The 19-item checklist has gone to show significant reduction in both mortality and morbidity, and is now used by a majority of surgical providers around the world. Each item on the checklist was selected to make surgery safer, and every single item is important. It was initially as a project, it was done in 8 hospitals worldwide. It was found to reduce the rate of postoperative complications and death by more than 1/3. What problems does this checklist address? Individually, if you see each item, before induction of anesthesia, has the patient confirmed identity, site, procedure, consent? Is the site marked? Before skin incision, confirm patient's name, procedure, whether the incision will be, where incision will be made, and before patient leaves operation theatre, nurse verbally confirms the name of procedure. So this gives correct patient, operation, and operative site. There have been 1,500 to 2,500 wrong site surgeries incidents every year in US. In survey of 1050 hand surgeons, 21% reported having performed wrong site surgery at least once in their career. Before induction of anesthesia, is the anesthesia machine and medication checklist complete? Is the pulse oximeter, there is monitors on the patient and is functioning? So anesthesia checklist, our cockpit drill is complete. And before skin incision, anesthetist again confirms, are there any patient-specific concerns? This provides safe anesthesia in resuscitation. Analysis of 1256 incidents involving general anesthesia in Australia showed that pulse oximetry on its own would have detected 85% of these complications. What problems does this checklist address? Again, before skin incision, has antibiotic prophylaxis been given within last 60 minutes? It minimizes the risk of infection. Giving antibiotics within 1 hour before incision can cut risk of surgical site infection by 50%. In the 8 evaluation sites, failure to give antibiotics on time occurred in almost 1/2 of the surgical patients who would otherwise benefit from timely administration. Before skin incision, confirm all team members have introduced themselves by name. Before patient leaves OR, surgeons and anesthetist nurse, what are the key concerns for recovery and management of this patient? This creates effective teamwork. Communication is a root cause of nearly 70% of the events reported in a joint commission from 1995 to 2005. The preoperative team briefing was associated with enhanced prophylactic antibiotic choice and aiming and appropriate maintenance and appropriate temperature and glycemia. So easy maths, 234 million people are operated each year, and more than 1 million of these individuals die from complications. At least half are avoidable with checklist. 500,000 lives on the earth can be saved each year. So these are the resources. WHO Safe Surgery organization, and the things are available on the site. Are checklist, brochure, FAQs, how to do video implementation. Implementation manual is very important. Guidelines and starter kits. Thank you very much.
Thank you, Asit sir. That was a very nice talk on something very, very vital. My request to every private practicing anesthesiologist will be to please take a printout of these WHO guidelines and please give it to your surgeons if they are not using it in your nursing homes. The guidelines of National ISA that we are updating for the practitioners, we have included these guidelines, and definitely in the next 1 or 2 months, they will be unfurled, and you will have it on our ISA website very soon. So thank you, Dr. Asit sir. That was a very nice talk. And I invite the next speaker, Dr. Rajnendra Sharma. He's from Rajasthan. He'll be talking on embracing the change. That is remuneration in Rajasthan anesthesia practices. This is what I've been telling, you can start sharing screen, Dr. Rajnendra Sharma. This is what I've been telling, every city is different. The charges in one state itself, you'll find how variable they are in each city. And I feel Dr. Sharma has done a wonderful job of collecting all the charges in his state. And I feel over to Dr. Rajnendra Sharma, please. Please, sir.
Am I audible, sir?
Yes, sir.
Yes, sir. Yes, sir. Okay, sir. Good evening to one and all. The topic for given to me for today's webinar is remuneration in Rajasthan anesthesia practice. So slide is
next.
Sir, slide next is
do the next.
Yeah. Oh, yeah, but it is not.
Next slide on the laptop or
Yeah,
computer,
yeah,
whatever you are using.
I'm
do the next.
Stop sharing, but yeah, now again sharing. Okay. Yes, sir.
Yeah. No, just on the keyboard, press the next, sir.
Yes, yeah.
Press the next.
Sir. Definitely, sir. It's not working. Yes, sir. Now it's coming. So, the major cities of
full screen,
Rajasthan.
sir. Full screen.
Yeah.
Full screen.
Yeah. There is some problem is having.
You can go to slideshow, sir. ऊपर की तरफ slideshow है, उधर चले जाइए. Now, yes, press that.
Yes.
So from current slide.
It's not.
Dr. Mukesh, can we do it from our side?
Dr. Mugish, please.
Yeah. Is it okay, sir? Hello.
Yeah, fine, Dr. Rajendra, fine.
Yes.
Go ahead.
Yes, sir. So, the major cities of Rajasthan are Jaipur, Jodhpur, Udaipur, Kota, Ajmer, Bikaner, and Bhilwara. And the coordinators are Dr. Ajay Gupta, Dr. Kusum Agrawal, Dr. Rajneendra, Dr. Sunil Rawat, Dr. Vivek Sharma, Dr. R.N. Vijay, and Dr. Manish Malav. Now, some of the facts about the anesthesia charges in Rajasthan. The anesthesia charges differs from city to city, and some places charges are very low, while at other places they are quite respectable. But overall, if we compare with the national standards, the anesthesia charges what the anesthetists are getting in Rajasthan are low. The charges that will be discussed here is sourced from respective city charges, anesthesia charge list, or obtained from the leading practitioners in the cities where the lists are not followed. Even in the same city, the charges differ due to patients coming under different schemes like Bhamashaya scheme or Chiranjeevi scheme or Mukhyamantri Ayushman Arogya Yojana or Rajasthan Government Health Services or Janari Suraksha Yojana, where the package charges for every operation is so less that hospital cuts anesthesia charges. Free camps in medical college are also deterrent to the anesthesia charges. In majority of cities, there is a widespread undercutting of charges by fellow anesthetists that makes implementation of revised charges difficult. The general charges or the minimum anesthesia charges are for as PSC charges. It ranges from 300 rupees to 1,000 rupees in different cities of Rajasthan. The ICU call for intubation or ventilator settings, it ranges from 1,500 to 3,000 rupees. Then for central line insertion, it ranges from 2,000 rupees to 4,000 rupees. Then for epidural steroid, it ranges from 2,000 rupees to 3,000 rupees. For lumbar puncture and rise tube insertion, it takes around 1,500 to 2,000 rupees. For MRI call for sedation, it is around 1,500 rupees to 3,000 rupees. And night charges extra are from 500 rupees to 1,000 rupees. And extra charges as applicable are around 15,000 per hour in different cities to 2,000 per hour, and then later on as per time is applicable. Then ops and gynae anesthesia charges in Rajasthan, LSCS, daytime LSCS, or as per astrology time, the anesthesia charges varies from 2,000 rupees to 4,000 rupees in different cities of Rajasthan. For abdominal hysterectomy, open abdominal hysterectomy, it is from 2,000 rupees to 4,000 rupees. For total laparoscopic hysterectomy or lap-assisted vaginal hysterectomy, it varies from 2,000 to 6,000 rupees. Then ectopic, open ectopic or lap ectopic, it ranges from 2,000 to 4,500 rupees. For MTP, DNC, and os tightening, it ranges from 500 rupees to 2,000 rupees in different cities of Rajasthan. Then for hysteroscopy, diagnostic hysteroscopy to hysterolaparoscopy, it ranges from 1,800 rupees to 3,000 rupees. And for myomectomy, it is 3,500 rupees to 5,000 rupees. For general surgery cases, the anesthesia charges for inguinal hernia open for unilateral and bilateral, it ranges from 2,000 rupees to 4,500 rupees in different cities. And for lap inguinal hernia, unilateral or bilateral, it ranges from 3,000 rupees to 6,000 rupees. For lap inguinal hernia, it ranges from 3,000 rupees to 6,000 rupees. Then appendicectomy, open and lap, it ranges from 2,000 rupees to 4,500 rupees in different cities. Then Cholecystomy open, although it is done less in different cities. Laparoscopic cholecystomy, it ranges from 2,000 rupees to 5,000 rupees. Then exploratory laparotomy for perforation and obstruction, and it ranges from 2,500 rupees to 5,000 rupees as per time permits, as per time. Then for piles, fistula, and fissure surgeries, it ranges from 1,500 rupees to 3,000 rupees in different cities. For breast lump or MRM surgery, it ranges from 2,000 rupees to 6,000 rupees. Then for hydrocele and orchidectomy, it ranges from 2,000 rupees to 3,500 rupees. And for larger, longer cases like splenectomy and nephrectomy, it is right from 2,000 rupees for per 1 to 2 hours to 4,000 or 5,000 according to time. Then for thyroid and parathyroid, it ranges from 2,500 to 5,000 rupees. For orthopedics cases, for closed K-wire fixation, it ranges from 1,500 to 3,000 rupees. Then for spine surgeries, laminectomy fixation, it ranges from 3,000 rupees to 7,000 rupees. For interlocking nailing of femur, tibia, and humerus, it ranges from 2,000 rupees to 4,000 rupees. For IT fracture or DHS or PFN or TFN, it ranges from 2,000 rupees to 4,000 rupees. For plating of forearm bones, single or both bones, it ranges from 2,000 rupees to 4,000 rupees. Then plating of humerus, femur, and tibia, it ranges from 2,500 rupees to 5,000 rupees. Then THR, PKR, unilateral or bilateral, it ranges from around 4,500 rupees to 10,000 rupees. Then arthroscopic repair, ACL, PCL, or shoulder joint, then it ranges from 2,500 rupees to 10,000 rupees in different cities. Then tension band wiring of patella, ankle, and olecranon, it ranges from 2,000 rupees to 3,500 rupees. For bipolar cemented, it ranges from 2,500 rupees to 5,000 rupees. And for neurosurgery, for DJ stenting unilateral or bilateral, it ranges from 1,500 to 2,500. For cystoscopy, diagnostic or dilatational, it is 1,500 rupees to 2,500 rupees. For VIU, stricture or urethra or open bladder stone, it ranges from 2,000 to 3,000 rupees. For URSL, unilateral and bilateral, it ranges from 2,000 to 4,000 rupees. For pyelolithotomy and pyeloplasty, it ranges from 2,500 to 5,000 rupees. For PCNL and RIRS, it ranges from 2,500 to 5,000 rupees. And for TURP and TUR resection of bladder tumor, it ranges from 2,000 rupees to 4,000 rupees. For nephrectomy, it is always according to time, but it ranges from 4,000 to 6,000 rupees. Then for neuro surgery, then for craniotomy, it is 3,000 to 3,000 to 6,000 rupees and plus time. Then for meningioma, it is around 4,000 rupees to 7,000 rupees if it is less than for 3 hours and more as per time factor. Then for burr hole and decompression, it is 3,000 rupees to 5,000 rupees. For VP shunt and cranioplasty, it is 4,000 to 5,000 rupees. For cervical spine, it is from 3,500 to 7,000 rupees plus time. Then laminectomy, corpectomy, it is 4,000 rupees to 6,000 rupees. And other major surgeries according to time, if it is less than 3 hours, aneurysm clipping or lighted, it is 15,000 to 7,000 to 15,000. Then anesthesia charges for ENT surgery, adenoids, and thyroglossalsis, it is from 2,000 rupees to 3,000 rupees. For tonsillectomy, it is from 2,000 rupees to 3,500 rupees. For septoplasty and tympanoplasty, it is 1,500 rupees to 3,500 rupees. For vocal nodule or macular surgery, it is from 2,000 rupees to 4,000 rupees. For thyroid and parotid surgeries, it ranges from 2,500 rupees to 5,000 rupees. For polyps or breast surgery, it is 3,500 rupees to 4,500 rupees. For foreign body esophagus, ear, and foreign body nose, it ranges from 1,500 rupees to 2,500 rupees. For foreign body trachea, it ranges from 2,000 to 5,000 rupees. For mastectomy, it ranges from 2,000 rupees to 6,000 rupees. For carcinoma larynx, it is always depend on time, but it nearly about 5,000 rupees to 12,000 rupees. Then for pediatric surgeries, it ranges from 1,500 rupees circumcision, from 1,500 rupees to 2,000 rupees. Herniatomy, it ranges from 1,800 rupees to 3,000 rupees. Appendixectomy, it ranges from 2,500 rupees to 4,000 rupees. Laparotomy, it ranges from 3,000 rupees to 7,000 rupees. TOF and CDH, it depends on time, how much it takes. It is around 6,000 to 7,000 plus. And cross rotation flap, it is 6,000 to 7,000 plus, and free flap from 8,000 to 10,000 plus. Then plastic surgery, cleft lip palate, it ranges from 2,000 to 5,000. Then debridement and SSG, it is 1,500 to 4,000. Then rhinoplasty, it is 5,000 to 6,000 rupees. Burn contracture release, it is around 4,000 to 5,000 rupees. Maxillofacial surgery, again, it is time dependent. So 3,000 rupees to 6,000 rupees plus time. And then liposuction surgery is 4,000 to 5,000 rupees. Hypospadias, 4,000 rupees to 5,000 rupees. And cross leg flap, it is also already for a time, it is from 2,500 to 5,000 rupees. And vascular repair, it is 4,000 to 5,000 rupees. In ophthalmic surgeries, the charges are for cataract surgeries under MAC or monitored anesthesia care, or if it is under GA, then it ranges from 800 rupees to 4,000 rupees. And for corneal tear repair, it is from 3,000 rupees to 3,500 rupees. For squint surgery, unilateral or bilateral, it is 3,000 or to 4,000 rupees. For vitrectomy, it is around 4,000 to 4,500 rupees. Syringing and probing or foreign body eye, it is around 2,000 rupees. And for DCR, open or endoscopic, it is from 3,000 to 4,000 rupees. Thank you, sir.
Thank you, Dr. Rajendra. That was a very difficult job for you to compile all this one, but I feel you did a good job. And what I'm trying to, the idea of taking this talk was that you must realize that in a single state, there is so much variability in the charges. The charges
Yes,
are
sir,
pretty decent, but at the same time, I feel we have at National ISA, we have requested every city branch to come out with their minimum charges. The minimum charges have to be the minimum in the whole city. The maximum can be anything.
Yes,
so please, again, requesting all the city branch presidents and secretaries to come out with their list, which has become so very important today. And I feel it's, thank you, sir. It was a very nice talk. Coming to the next talk, Dr. Prajakta Aire from Maharashtra. She'll be talking on Balancing Act, investments and asset allocation for the anesthesiologist. I feel parallel source of income is very important today. And I feel Prajakta will be throwing more light on it, what it is to have in your kitty. If you really want to be financially independent, FIRE is a new community which has come in the being. You can start sharing the screen, Dr. Prajakta.
Yes, sir. Yes, sir.
So I request each of you to think of parallel sources of income in whatever best way you feel is your risk-taking ability. You may be in stocks, you may be in mutual funds, you may be in land, you may be in gold, whatever. Prajakta will give us some guidelines what she feels is best for us. Over to you, Prajakta.
Thank you, sir. Am I audible, sir?
Yes.
Yes.
Okay.
Very
Screen
much.
is seen, sir.
Yes.
Okay. Good evening, everyone. Thank you, Bajwa sir, Pankaj Gupta sir, and Tendulkar sir for giving me the opportunity to talk and share my thoughts. My today's topic is asset allocation. It is more of a question and answers. Although I will be talking my answers, I request all of you to answer my questions in your mind. So here I start. My first question is, can financial literacy make the journey better? My answer is yes. The next question, how? I think the purpose of this webinar is to make our private practice better and peaceful. Many problems and solutions are discussed by many speakers here till now. I have different kind of solution for our private practitioners. Let me start with first principle thinking, which tells us to dissect the problem to atomic level by asking the question why. So, answer my question, why do we work? The obvious answer is to make money. Because it is needed for survival, it fulfills our dreams and it satisfies our ego. But it is not the only reason we work for. We do have other human needs, that is socialization, creativity, having purpose in life, to feel worthy and confident. I will ask my next question. Is it possible to earn from other sources along with anesthesia practice? Please note, I said along with and not instead of. So my answer is yes. Again a question. Akhir kyun? Why? Because we do have problems like less paying, dominating surgeon, growing competition. Just now we talked about, BMS, MD anesthetists, poor working conditions, and we do have solutions. Few are outside, like remaining updated, learning newer skills and technologies, and learning about newer drugs. The other solution is inside, within us. That is to feel secure and confident while dealing with different situations in OT and dealing with different kinds of surgeons. So again a question, how to feel confident and secure? Let me ask you another question. What if you get 12 lakhs per annum from a source other than anesthesia? Will these 12 lakhs increase your confidence and feel you secure while dealing with a surgeon or while taking a high-risk call? I think it will give you courage to say no to an uncomfortable case. It will give you freedom to choose your surgeons. I am sharing few screenshots of anesthetists from different cities of Maharashtra who earned money in financial year 23-24 apart from anesthesia from different source. The names are not real, but profits are real. Dr. Anjali earned 51 lakhs rupees in one financial year. Dr. Rahul earned 13 lakhs and Dr. Prem earned 19 lakhs rupees. So again a question, how to reach this stage? Please remember, we are not going to be Rajpal Yadav and get trapped in some Akshay Kumar scheme, 25 din mein paisa double. The only way is get the knowledge, make sure only you are not working, but your money too is working for your progress. Get the inflation beating returns. To get the returns, we have different asset classes like equity, real estate, gold, and debt products. By investing in equity, we get the capital gain, we get the dividend, and hence our money grows. If you have more expertise, more knowledge, you can do trading and get the profit. By investing in real estate, our money grows by getting rent and capital appreciation, and debt products and gold do give capital gain. Someone may say, why is the need of asset allocation? If I like, I will invest in real estate, and if I don't like, I will not put money in equity, that is share market. But let me tell you, asset allocation is necessary to reduce the risk of portfolio while optimizing the returns. Asset allocation is depends on age, risk appetite of a person, and duration of investment. For example, for 70 or 80 years of age, equity exposure should be minimal or nil. Also, the person who is less risk taking or risk averse, he will not put his money in equity. If one needs money in 1 or 2 years, he should refrain putting money in share market related instrument. There are many formulae available on Google for asset allocation. The most commonly used is 100 minus age should be equity proportion. For example, if one is 30 years old, his portfolio, 70% of his portfolio should be exposed to equity related instruments. But I follow Wilcon's GERD formula. Up to 50 years of age, gold and debt products instruments, exposure should be 10% and equity and real estate exposure should be around 40%. Note that equity and real estates are only two instruments or asset classes which give inflation beating returns. But gold and debt products, although they deliver less returns, they give stability to the portfolio in times of volatility. When we go for investment in gold, we have three asset classes. Three instruments. Physical gold, everyone must be aware of. Gold ETF or mutual funds and sovereign gold bond. My favorite is sovereign gold bond. These are the bonds issued by RBI with sovereign guarantee. If you apply for it online, you get the discount. You get the 2.5% interest per annum on your investment. And the most important is capital gain is tax-free if you keep it for a locking period of 8 years. If you go for physical gold, you pay 3% GST. You need locker for its safety and security, where you pay locker charges to the bank. If you go for gold MF or ETF, you have expense ratio, which again reduces your return. And the most important is physical gold or gold mutual funds. Capital gain is taxable at your slab rate. So, consider you are buying HGB today, considering 100 gram, considering 10 gram gold 70,000. So for 100 gram, you put 7 lakh rupees, 2.5 interest per annum is 17,500 per year. A total 8-year interest will be 1.4 lakh. Someone may feel this 1.4 lakh in 8 years is a less amount. But just imagine how many spinals you give to earn this 1.4 lakh rupees. And the most important is capital is tax-free. Assume after 8 years, suppose the gold value becomes 1 lakh per 10 grams. So your total investment value is 10 lakhs, capital gain of 3 lakhs. If you are in 30% tax bracket, you will pay 90,000 rupees tax and your total gain will be 2.1 lakh. Whereas in HGB, the tax, it is tax-free capital gain. So total 3 lakh will be your capital gain. The next asset class is equity. Knowledge is needed to invest in equity. The level of knowledge is like, MBBS, post-graduation and super specialization. By doing MBBS, you can start the general practice. Like similarly, for investment in mutual fund or ETF, the basic knowledge is needed. And with that knowledge, you can invest in mutual fund. I suggest to go for direct mutual fund without involving any agent. So that saves your commission. With doing post-graduation, that is, after gaining a particular knowledge, you can invest in direct equities, that is shares. It needs expertise to choose your company. And by super specialization, like cardiac anesthesia, you can do trading. But believe me, it is really super specialization. Otherwise, you may lose money in trading. Titan share rose from 100 to rupees 3,500 in last 17 years. So 1 lakh investment 17 years before is now worth rupees 35 lakhs. But wait, in same period, Reliance Communication fell to 1 rupees from 800. So 1 lakh has become zero almost. So that is why I said it really needs study, reading, practice, patience, and expertise. The next asset class is real estate. It does give inflation beating returns. You can invest in commercial or residential properties, but it has few drawbacks. It needs large chunk of money, so it is difficult for beginner. It is illiquid. One may not sell the property in times of need. It may have few legal issues, and yes, maintenance cost will always be there. The last asset class is debt products, debt instruments. These are the instruments which are not associated with share market. So these are FD, RD, various debt mutual funds like liquid fund, short duration fund, ultra short fund, and various post office schemes like PPF, Sukanya Samruddhi Yojana, Kisan Vikas Patra, etc. So my take home message is read, study, shift from literate to financially literate. Dr. Sahar said one word, stop loss. This means many of our fellow colleagues, anesthetists, are financially literate, doing good in equity market. Take their help. Those who are financially literate and know the money management, let us help others. Let us rise together. Let us grow together. Thank you.
Excellent, Dr. Prajakta. You did full justice to the topic and your punchlines were superb. I wanted everyone to have proper take-home messages. So I feel, just remember one thing. I know one anesthetist who was asking me, sir, I have 90 lakhs in FD. So please don't do that. FD is one of the worst forms of savings. Or in life, let our investments grow for you. Money should make money grow, maybe actively, maybe passively. If you have any of you want to join our groups, please do contact me or Virendra, and we will add you to our financial groups where we keep teaching all such things. Thank you, Prajakta. That was very nice. And
Thank
of course, one very important thing I would like to say is no one size fits all. Each one of us has to decide his own risk appetite and accordingly decide where they want to invest. Thank you. Thank you once again, Prajakta.
Thank you, sir. Thank
Coming
you.
now to the next talk, one of the most important and I feel most vital talk I would say is by none other than our Dr. Pratibha Kane madam, whom I feel whenever I want anything medical, I just think of her directly. She's done a wonderful job even in upgrading our guidelines, which will be coming out very soon. So blind spot is one thing which many of us in private practice are not aware of. So I feel I'll hand it over to madam and she will be talking on the medical implications of anesthesia practice. Please, madam, please start.
I'm sharing my screen now.
Make it full screen, madam.
Yeah, can you see that?
Yes, madam. Your screen is there, but it's not full screen. Just make it full screen.
Yeah, okay.
Yeah.
Is that okay?
Perfect, madam.
Hello?
Yes, yes, madam. Perfect.
All right. Okay. So I thank Dr. Pankaj and all the ISA dignitaries here for this invitation to take part in this prestigious webinar, which is, and I have been given the responsibility of shedding light on a blind spot, which is medical negligence in anesthesia practice. So, let me tell you something about medical negligence. It is not a codified law. And generally, when we speak of medical negligence, it is an act or omission which a prudent or reasonable doctor would never have committed. And to prove medical negligence, we have to have two conditions have to be established. One is that the doctor does not have the necessary skills, which is the qualifications, and the other is and the other that he has not exercised these skills in accordance to established standard of care at that time and in that locality. So the patient or the relatives have to prove that the doctor had a legal duty, there was a breach of this duty, and there were some complications or injury. And then this patient or the relatives can claim compensation. So monetary compensation, they go to the consumer court. If they want to make a criminal case, they can file an FIR. And if they can even approach the State Medical Council to revoke or suspend our license to practice. Now, after this landmark judgment of Mumbai Grahak Panchayat versus Dr. Rashmi Fadnavis, it has been clearly stated that the anesthetist is an independent professional hired for service. He is not under the direct orders of the surgeon or the hospital. So there is no master-servant relationship. And the patient is our customer as he pays for our services. And the anesthetist now is separately liable for negligence under the CPA Act. Now, this is yesterday's news. It has been circulated. So the objective of this webinar in this rising condition of filing medical malpractice cases is to understand some of the issues, because I've been given very little time, which can be litigated to try to prevent litigation, if possible, or even to be able to offer a very strong defense in case any litigation happens. So now let's start with the first and most important is, do you have the necessary qualifications? And are you registered? Is the place where you practice registered? So now this interesting case of Ruby Hall Clinic, a 5-year-old child who had renal stones was operated under general anesthesia. The patient post-operatively had hypotension, bradycardia, and died the same day. Now, on investigation, it was found that the doctor who administered anesthesia in this prestigious hospital for 30 years did not have the proper degree in anesthesia. He was an extremely efficient and well-known anesthesiologist. So the hospital has been held negligent for employing non-qualified anesthetists. So please do check, do not practice beyond your qualifications, especially super specialty. I know of many cardiac anesthetists who do not have proper documentation or qualification certificates. If we are using the ultrasound for any purpose, please see that you are registered with the PCPNDT local authority. And the new NMC regulations definitely highlight that association with unqualified persons is not acceptable. So now coming to the pre-anesthesia evaluation. Now, not having this document by itself is deficiency of service or negligence in many of the cases. In this case, which is a landmark case, the anesthesiologist and cardiologist noticed hypertension, but no further tests were done. ECG was also not done. A young patient for a non-emergency fixation of radial deformity. The patient had a cardiac arrest during surgery and died. Now, it was negligence was held, and for not investigating further, and look at the apportionment of charges. It is a 4,15,000. This is in, please understand, this is in 1996. Today, you can imagine what this amount will be. But the apportionment of charges is very interesting. It's 60% to the anesthetist, 30% to the orthopedic surgeon, and even cardiologist has been made liable. Now, in this next case, which is also a very famous case, spinal anesthesia was given to a young patient with fractured tibia. Now, the pre-anesthesia check was not done and the history of head injury was missed. This anesthetist has been held negligent, not just under the CPA, but also booked for a criminal charge. And this, I'm talking about 2001. In this next case, which is also very interesting, on induction of anesthesia, the patient develops bronchospasm. Now, and the patient, it could not be revived and the patient dies. Now, in the defense, the anesthetist says that the patient had history of asthma, but this asthma was not mentioned anywhere in the pre-anesthesia check and it was not accepted. So when we plan for anesthesia after a pre-anesthesia check, please see that the document has all the comorbidities, the preferences of the patient, any limitations of infrastructure which has been informed to the patient, any optimization or referencing which is required. Now, so any delay, any cancellation, any need for shifting to a higher center for greater risk must be discussed with or communicated with the surgeon and the reasons explained to the patient. Now, coming to an important aspect of anesthesia care is a separate anesthesia consent. It is really required because the risk of anesthesia is over and above the risk of surgery. Now, the consent must be also specific. In this first case, the consent was taken for a general anesthesia, for an abdominal hysterectomy, epidural spinal was given, and a vaginal hysterectomy was done. There were many complications, and they found that the consent was invalid. Now, we all know that we should not go beyond the consent in any non-emergency situation, even if it is for the benefit of the patient. Please refrain your surgeons when they try to remove a mole or try to remove some breast lump or something when the consent is not taken. There are other reasons which are very common, that the patient is competent, but the relatives have given signature on the consent form. So in this first case, the patient is 18 years, but the mother has signed. In the second case, the patient is 80 years old, but he walks to the endoscopy unit and has a cardiac arrest in the endoscopy unit. And when they do investigate or scrutinize the consent, they find that only the daughter has signed, means the patient was definitely competent to sign, and almost 5 lakhs has been awarded. And so because the consent is invalid, we definitely need a consent for transfusion of blood or blood products. Invalid consent can also be litigated in the criminal case. In this case, 11 doctors were booked under 350 criminal force and 351 assault in a famous Pune center. Here, the mother of a girl who was operated for a valve replacement said that the risks were not explained, and this was held as a criminal charge. Of course, we all know that in emergency, consent is not required, and operating in good faith without the patient's consent, we do get protection from the IPC section 92, and this public interest litigation of Parmanand Katara has said that human life is more important than legal formalities. So it does give us protection to operate in good faith. There are many times when when surgeries have been delayed for lack of consent. Usually it is because payments have not been made, and they say that if the relatives were not there to give consent. But this must never be done, and all emergency surgeries must be, we must keep the patient in mind. In this case, a 15-year-old patient died because they did not operate for appendectomy, and the surgeon has been made negligent. Let's look at some intraoperative deficiencies which can cause litigation. So we've all heard of the wrong side, the importance of surgical checklist and timeout. Now, this is in Fortis Hospital in 2022, and they operated on the wrong leg. And then, of course, anesthetist was also involved, and now anesthetist gives a defense that I gave spinal anesthesia, and after that, I do not know what happened. Now, this is definitely not acceptable. They have said that in the interest of the patient safety, you have to be involved with what is happening in the operation theater. The teamwork is really, really important. And let me give you one more example. This is a criminal case. Now, two surgeons, one anesthetist, and a nurse has been booked for leaving a surgical mop in the abdomen. Now, you will say, how is the anesthetist involved? It is not acceptable that we can say that, yeah, this is the surgeon's problem. No, we have to think of the patient's interest. This patient herself was a doctor, and now there's this new trend of involving everybody. They have involved everybody under the IPC section 34. This is criminal conspiracy. That means everybody was negligent and, did not really check that the mop count was correct. So please understand that we are a part of the team. Do not, keep everything, kind of be vigilant in the interest of patient. Now, this is a 2023 verdict that anesthetists and surgeons have been told to pay 33 lakhs as compensation after a patient's death during a laparoscopic cystectomy. And the diagnosis was CO2 embolism. Now, you can imagine that if the ETCO2 monitoring was done for this case, maybe the early warning signs would have prevented this death. And if you really look at this 33 lakhs, one can get at least 7 to 8 ETCO2 monitors. And I would really, on this forum, ask everybody to try to at least acquire this monitoring equipment. Extremely, extremely valuable to prevent death and also the agony of a table death. No defibrillator has been the point of holding negligence in many Consumer Protection Act cases. And actually, the judges have called the anesthetist careless, callous, and overconfident for working without a defibrillator. Now, not having the facility to give blood transfusion for PPH is 100% negligence. In this criminal case, the Karnataka court has convicted 3 doctors for death of a woman for working without a ventilator facility and other life-saving equipment. And of course, anesthetist is involved in this. So when undertaking, high-risk cases, one must have at least some access to an ICU setup, or one should be able to transfer early. Now, allegations of anesthesia overdose are very, very common, especially when children are involved and the death under anesthesia. So one must be really very careful about dosages and must have some pediatric anesthesia experience to undertake these patients. Now, this is Sutcliffe versus Entry Hospitals in 2008 made the headlines. This was about anesthesia in UK, and this was about serious anesthesia drug error when chlorhexidine was injected for labor analgesia instead of bupivacaine. And the judge over there has very clearly stated that haste and flurry in an area needing the highest standards is not acceptable and is 100% negligence, and awarded one of the highest compensations of that time. And I myself have heard of many cases where beta-log tranexamic acid has been injected in the epidural and spinal spaces, and the simple solution of reading back labels before drawing medications for CNB should not be skipped. Smartphones are a definite distraction. And in this very interesting case, I would like to just share with you all, this is a Dallas case of 2014. A 61-year-old patient was undergoing a routine pacemaker placement, and hypotension was missed for almost 20 minutes, and the patient went into hypoxic damage and died after 10 days. Now, it is very easy to find out what you were doing in those 20 minutes, okay? So they found out that the anesthetist was browsing for those 20 minutes and also had made 2 Facebook postings. And the case, of course, got settled before going to trial because they would have really, kind of given a very, very high compensation. I would like everybody to understand about patient confidentiality and privacy. Please do not share any material that you see in the operation theaters on social media. If you want to have any live demonstrations, or now there's a big debate going on live surgeries, but if you want to project any of your content which you have learned during your managing your cases, the specific patient consent for what we are going to use it for is required. Now, poor documentation is definitely poor defense, and no documentation makes no defense. Now, in this very interesting case of Meenakshi Mission Hospital, the child was there for cleft lip surgery, has a cardiac arrest and dies. They find on investigation that there were 2 anesthetists in the OT, 2 anesthesia records with different time of arrest. And the name of the anesthetist is not seen in any of the records, and they have made the hospital liable for negligence. Now here, this is 2018, Apollo Chennai, a 29-year-old patient only for examination under anesthesia for a hemorrhoidectomy pain. He has a cardiac arrest in the recovery room, and which gets revived, but the patient later has a brainstem dysfunction and dies. There are no CPR notes, and this has been taken as res ipsa loquitur. And look at the compensation awarded. Deficiency of service with 57,64,000 to be paid by 4 parties. Of course, one of them is the anesthetist. Now, fabrication of documents is a definite no-no. And this is a very interesting case which was, the judgment came out in May last year. Here, a pregnant patient has walked to the operation theater, and within 2 hours, she was declared dead. Now, at the post-mortem, it was found that the patient had a fracture pelvis, and about 2,000 ml of blood was in the abdominal cavity. Now, the anesthetist has written his notes that the patient had anaphylaxis. So the court has actually asked this anesthetist to explain how anaphylaxis can cause a fracture and how it can cause blood in the abdominal cavity. Of course, the anesthetist has been held guilty, and the compensation, look at the compensation, 1.6 crores. Of course, most of it has to be paid by the hospital. Anyway, so fabrication of documents is also a criminal, I mean, it's a criminal case. And you can be, it is like forgery, and you can be indicted in any of the under those headings of the IPC. So post-op concerns are definitely a problem in a solo anesthesia practice, because who is going to be responsible once the anesthetist leaves? In this case, the surgeon and the anesthetist had left, leaving the patient with the juniors and nurses. And though this is a 2004 case, 4 lakhs has been awarded because the patient went into hypoxia and could not be saved. Not transferring early to bigger hospitals or to the ICU has been held as negligence. Anesthetist not accompanying the patient while transfer has been held as negligence. And in this post-op spinal hematomas, I have put it up over here because diagnosing it early enough can be almost, you can save the patient of paraplegia. In this patient with LSCS, it went unattended for almost 14 hours. And the MCI actually has suspended the license of the gynecologist and anesthesiologist for missing this for 15 days. This is in 2018. This is another case from the Maharashtra State Commission, and this is spinal hematoma leading to paralysis and death after TKR surgery. NORA practice is another area which our standards should be as high as we maintain in the operation theater. There are many deaths in the endoscopy unit, on the dentist chair, and in the MRI units. And the blame goes squarely on the anesthesiologist's shoulder. So to conclude, I would just like to say that in case of adverse events and critical events, do not hesitate to call for help. That's the best thing that you can do for yourself and for the patient. Call a local senior colleague, or call an ISA senior office bearer, call Dr. Pankaj. And it is definitely something that is required to prevent the creation of a second victim. Because of lack of time, I do not have time to explain that. But I can just conclude by saying that anesthesia specialty is a tightrope balance. But if we keep the focus on patient safety, there lies our own safety. Thank you. Thank you, everybody.
Thank you, madam. That was an extremely sensitizing talk, and I'm so happy that our guidelines that are being updated have been screened thoroughly by you from the medical legal point of view. Thanks a lot. I feel now we will go to the panel discussion, and I hand over the stage to the two moderators, Dr. Ganesh Tendulkar and Dr. Tejveer Chauhan, who will be conducting the panel discussion. This will be followed by some question answers which the delegates may have put on the on the group. That I feel our moderators will look after the panel discussion. Over to you, Dr. Ganesh and Dr. Tejveer.
Good evening,
Virendra
everyone.
Sharma is also online. Good to see you, Virendra.
Yeah. Good evening, everyone. Dr. Shakil sir, Dr. Shakil Momin sir, is he available today? So my first question is for Dr. Shakil Momin sir, our panelist.
So you can direct to whomever is available then. Dr. Virendra Sharma is there. You can unmute him.
Good
He's there. He's there. He's there.
Good evening, sir. Good evening, sir. My first question is to you, sir, and this is regarding Dr. Sir's talk. What's your experience about the newcomers who joins a freelance practice? How is he welcomed in the group, rather ISA branch? Are they accommodated well, and do they participate in ISA academic activities?
Yeah, if I start with my own experience when I was junior, the things were quite difficult. At that time, there were very few people available. So, am I audible clearly?
Yes,
I
sir.
think I am
Very
not
much, sir.
visible.
Yes, sir.
Yes,
Very well.
I'm
Yes,
not
sir.
visible probably. Okay. That time I was 10th to join in the city. So what I did first is I met surgeons and anesthesiologist colleagues also.
माझा टॉपिक आहे आता.
Yes, Noel, you are going to talk.
Sorry.
Anyway, please mute your mic. So actually, what is important is if a new person comes to me, comes to my city, you should meet seniors, and seniors should not look at him as a competitor. They should look at him as a colleague, and there is no point in discouraging people, because even if you discourage, there is going to be somebody coming every year or maybe more also. So there is no point in discouraging. At the same time, the newcomer must know that the only person who is going to help him is in crisis is the fellow colleague anesthesiologist only. In our city, there were so many, in initial stage, there is so many complications. And for that, every anesthesiologist helped to each other. And we came out of the complication because of our unity only. So everybody must understand that your best friend, as far as anesthesia practice is concerned, is anesthesiologist only. Then regarding the search, this Thorwas talk, I want to point out a few things. There's a difference between the institutional practice and private practice. In institute, we get the best type of equipment where the patient is not paying or maybe least paying. And we are giving the worst kind of equipments we are using, not worst, the little less quality equipment or the cheaper paraphernalia is available for the anesthesia practice where patients are paying. So this is contradictory. But at the same time, we must remember that while administering anesthesia with limited resources, we have to use highest quality of skill and highest quality of knowledge. So every private practitioner, in my opinion, is the better as far as skill is concerned and knowledge knowledge is concerned to manage within that with the limited resources. Yes, Ganesh, anything else you want?
Yeah, no, that was very comprehensive answer. My next question is to Dr. Pankaj Bade, but he's messaging that he needs to be unmuted. Can somebody unmute him? Dr. Pankaj Bade, are you around?
No. Yes, to unmute himself.
Hello?
Yes.
Yeah.
Hello. Yes,
Dr.
yes.
Pankaj, are you around? Dr. Pankaj is
Yes,
from
yes,
Jalgaon.
yes.
Welcome, Dr. Pankaj.
Thank
I
you,
would
sir.
like to ask you about Dr. Sir's talk only. Do you think a group practice can be a good option for a newcomer?
Yes, definitely. It is useful only in metro cities, just like Pune, Mumbai, because the newcomers they are not known by the surgeons or the hospitals. That's why that is for the introduction of them, and also easy to start the practice immediately. Immediate start they get, and security of practice also started due to group, and also the backup for high risk is provided by the seniors. in the group practice. So it is mainly for metro cities. At taluka and district places, it is difficult because the surgeons and hospital has the tendency to divide and rule on the anesthetists mainly.
That practice is everywhere actually. But anyways,
Yeah.
nice to know your view. Over to Dr. Tejveer regarding the questions on Dr. Dharmesh's talk.
Good evening, everyone. Again, my question would be to Pankaj Bade, sir. Dr. Dharmesh had talked about this setup owned by the anesthetist. Do you think there is a room for such kind of setups at taluka places in your area of practice or in other smaller places where anesthetist?
Definitely there is a means room for the setups in the taluka places. But my view is that it should be owned and run by the anesthesiologists, mostly the group of anesthesiologists, because surgeon, physicians, or other faculty person, they interfere with this thing because it requires communication and cooperation and equally put the consultants at a same platform, which doesn't happen with the anesthesiologist. That's why they gets exploited indirectly.
Thank you, sir. My next question is to Noel Brito, sir. Sir, what is your view on current MD anesthesia curriculum? Does it train the students adequately in the other skills like ICU management, chronic pain management, which can be used as to improve their work and income? Sir, please unmute yourself.
Anesthesia has come a long way. If you see from 60s, 70s, when I was studying in 87, it was called Department of Anesthesiology. Now it is Department of Anesthesiology, Critical Care and Pain. With the advent of gadgets, medicine, anesthetic agents, we have really come a long way. And I'm sure that the current, whatever medical college I have witnessed, the current MD anesthesiology curriculum provides a very solid foundation in anesthesia training. But definitely there is some room for improvement in ICU management, chronic pain management. And the curriculum should be updated to include more comprehensive training in these areas, as well as other emerging fields like pain medicine and critical care. So we have a robust education system as far as postgraduate anesthesia training is concerned.
Thank you, sir. Ganesh, sir, next question.
Yeah, my next question is regarding Dr. Asit Vaishnav's talk. And the question is to Dr. Jagruti Desai, madam, from Gujarat. Madam, are you around?
Yes, sir.
Yeah. Can you just enumerate the stepwise approach to a young anesthesiologist who intends to implement WHO checklist and standard anesthesia guidelines in various nursing homes he or she is visiting? Actually, the pitfalls and ways of overcoming them.
Yeah, very true, sir. As a freelancer practitioner, it is difficult for us to, though we feel that it is must, but it is difficult to implement all the time, though it is to be. But for teaching institute and corporate practices, it is a very good tool to correct our mistakes or whatever errors we are missing in routine practice, our anesthesia practice. But as I'm a private practitioner, for last some 10 years or so, I am putting everything on paper. As far as possible, I'm putting everything on paper. Not possible to do PAC in every case, but when I enter in the operation theater, I talk with the patient name and I start talking to them about the anesthesia plan, about what are their concern. So it is must. It is very difficult for freelancer practitioners because it could be sometimes repetitive, because nurses ask, the RMO doctors ask them about NBM and everything repeatedly. So sometimes confusing to the patient also. But minimum some amount of documentation is required. And what I have observed is that once you start writing and once you start documenting, you come across your mistakes and that you go on improving by yourself. So gradually I think we must make a habit of implementing WHO checklist. Most of the hospitals are having it, not all, but I think our aim would be to have at every place.
Okay, Dr. Tejveer.
Yeah.
Thank you, Dr. Jagruti.
Welcome.
Madam, actually, there is one more question for you. This is
Yes.
regarding Dr. Rajendra Sharma's talk. Can you draw a list of parallels or differences in freelance practice in Gujarat and Rajasthan regarding the remuneration part? Are they
Sir,
similar, you feel? Are they different?
yeah, remuneration part is like there is a lot of differences, be it in Rajasthan or be it in different centers in Gujarat. And for that matter, for the same center, like I'm practicing in Navsari, for me also there is a great difference in remuneration. Right, when the patient is from which class, which hospital, that depend upon that. If patient is, if tomorrow I have a case with PM Java Yojana TKR, so like the charges are very minimum, approximately some 3,000 around for TKR surgery. And but what my practice is, be it a special room or deluxe room patient, or be it a PMJY patient, the type of anesthesia, then post-operative analgesia is going to remain the same. Our services are going to remain the same, because we at least our duty is to do so. So remuneration is different, and gradually, and I'm telling you very frankly, even with the seniority, remuneration doesn't increases like in other branches. But I think we anesthesiologists are happy whatever we get, and I think happiness is the best medicine which you are taking.
We are very content, ma'am.
Right?
We are content with what we get many times. There's a question to Dr. Sarsh. You think junior and senior anesthetists will get paid differently for a longer time? Dr. Sarsh? Yeah.
I would just differ in that, sir. See, rather than paying, if it is one case, now the type of case which a junior and a senior would get, that is difficult. That is different. That would definitely be different. But if there is a simple case for which a junior and a senior is called, I don't really see whether there should be a difference in the payment. But if there is a case which is a high risk case which requires the expertise of a senior person, then of course yes, that senior anesthetist deserves, or he will be paid more as compared to any other junior anesthetist. But as far as a case is concerned, this is my opinion. As far as a case is concerned, if it's a simple case, then a junior and a senior anesthetist who are doing the same thing would be most probably paid the same amount. So the payment would not differ.
Is it a reality in Goa, sir?
Currently, yes, sir. Currently, yes. I have had senior anesthetists who have. We have been given the same. The choice of anesthetist would change only according to the how difficult the case is. The payment would not change. If it is a difficult case, the surgeon will actually wait for a senior anesthetist to come. He would not opt for a junior anesthetist. But if it's a simple case, the anesthetist charges is same for a junior as well as senior.
What about Dr. Rajendra sir's opinion? What's the situation in Rajasthan?
Unmute yourself, sir. Sir, unmute
Rajendra
yourself.
sir.
Please repeat your question, sir. Yeah.
Sir, the question is about Dr. Sir's talk. And do you think that junior and senior anesthesiologists are paid differently for any case? Say for a section or for a hysterectomy, for a DNC, for an orthopedic case? Are they paid differently?
No, sir. What sir said is the same. It is routinely it is the same for the juniors and seniors, and as they are used to giving the same charges to each and everyone.
Over to you then.
Only, sir. Only the high risk cases. In high risk cases, as rightly said by the sir, that they in high risk cases they call the senior most person, and in
Yes.
routine cases they call the anybody who charges less or anyone.
In Nasik, I would just like to comment. I found that the juniors charging much more than the seniors many a times. It happens city
Yes,
to
sir.
city, everything is different.
Yes, sir. Yes, sir.
Bade sir, Dr. Pankaj Bade, do you manage to
Yes.
get increase in anesthesia charges periodically, like after every 1 or 2 years? And how are they discussed? What points are raised by both the sides, like between anesthesia and surgeons? How do they decide?
And definitely, we are getting the rise in our charges periodically because from my side, always we put the things that inflation is going on. So we want a rise in our charges. Secondly, we are working as a means as a sole earning source as a anesthesia from anesthesia only. We are not a multiple earning source like a surgeon, except in a medical faculty, means in a medical profession. So just like surgeon has many earning sources like OPD, IPD, operative, referring, and whatever, pharma and all that. So this is one point from our side, and we can't hold the cases. Means if I get 3 to 4 more cases at the same time, so I can do only one. So in a day I can do 2 or 3 cases. So there is a limitation for work. So this is from our side. That is means from anesthesia side we tell to the surgeon these points, but the surgeon always resist, saying that there is a increased expenses and maintenance has gone rise, means maintenance has increased, and whatever means salaries has increased of the means our uh, uh, and all the packages are also less cashless, government schemes are there, and also we have to pay for the means through the packages, means packages are getting less and less, patients are not paying. These are the from the surgeon side they are telling.
Thank you, sir.
What's the average raise you get generally? Sorry, Tejveer.
Yeah.
What's the
Yes, sir.
average rate you manage to get after every 2-3 years? This is for the information of everyone.
5% or 10% we will get increase after 2 to 3 years. 5%.
I mean, Nasik,
thank
we
you,
send
sir.
a circular every 3 to 4 years. Every 3 to 4 years, we send a new circular. It's a common.
Okay.
Sir, I would like
Sir?
to ask Dr. Dharmesh Gandhi, because he was a freelancer. Now he's a hospital owner. So what is his take on periodic rise in anesthesia charges? Should they be increased? Like now, what he thinks, like as a owner or as anesthetist? Dr. Dharmesh Gandhi. Is he there?
Dharmesh has left.
He is there.
May I add in senior and junior charges?
Yes.
No. Dharmesh?
Dharmesh sir is not there, I think.
We can reserve the question for him. I'll just try to call him up. In the meantime, we'll move on to Prajakta. Prajakta Madam's lecture. The question is for Dr. Jagruti Desai regarding Prajakta Madam's asset allocation lecture. Do you think that time has arrived for a female anesthesiologist to plan her finances separately? And I would like you to give 3 important suggestions to a young female pass out regarding her finances. Dr. Jagruti?
Dr. Jagruti. I feel she's left.
Dr. Prajakta Madam, can you answer this question?
Yes, sir. Yes, sir. I can answer.
Please.
Am I audible?
Yes, very much.
Yes.
Okay. Sir, I think always it was a time when female, anesthetist, housewife, anybody should plan her finances separately. Having said this, it is a combined family, but she should be aware of all the financial planning of her husband as well as her financial planning. She should be actively involved, sir.
Okay. But what are the key 3 takeaways you can say? You can give it to any young female pass out who has just passed out her MD and anesthesia exam.
The first key out is the take-home message of my talk. Shift from literate to financially literate. Start investment at early age And generally, sir, what my experience, what my other female colleagues and friends feel, we do have lot of guilt for not giving our 100% to our career. We work less hours as compared to our male anesthesia colleagues. And this gives us lot of guilt and, not using total intellectual energy. So financial literacy, growing money, earning money from other sources, it fulfills our intellectual needs as well as it gives money. So guilt vanishes. So I will suggest this to freshly passed out. Don't feel
That was
guilty.
precise.
Find
That was
the
precise.
find the
Thank you so much.
solutions.
Thank you so much,
Very
madam.
nice.
Thank you so much, madam. And my question to Dr. Asit Vaishnav is, what's your take on retirement planning for a freelance practitioner? Dr. Asit, sir, are you around?
I am a failed person to answer on these things. At the age of 60, I started retirement planning. And still I am working for retirement planning. So,
Okay. So take home from your message is you should
starting
start
early.
planning very
Start
early.
early.
You should,
Started.
yeah.
Decide it
Prajakta
early.
madam, can you just explain in 2-3 lines what should be the take on the retirement planning of a freelancer?
So we should plan as early as possible. And please consider we will not be getting pension. So I think our own anesthetist, Diggaj anesthetist, Rajnikant Gajjar sirs, few strategies are there for retirement planning. We can get it through our WhatsApp group and start the retirement planning monthly or yearly. Keep some corpus for retirement planning. Invest, grow your money, sir.
Okay, thank you, madam. Dr. Tejveer? Dr. Tejveer?
You are muted. Unmute yourself.
Yes, sir.
Yeah, please go ahead with questions regarding Dr. Kani madam's talk.
Yeah, that is the most interesting part actually. Well, there were lots of questions with us also and with the audience also. My questions are to Dr. Brito, sir. Does group practice provide any safety net against medical legal cases in private practice?
Yeah, group practice can provide a safety net against medical legal cases in private practice to some extent, because when multiple physicians work together, they can share knowledge, expertise, responsibilities, and reducing the likelihood of errors and omissions. However, individual accountability and vigilance will always be there. Accountability will always be there individually.
Yes.
But definitely it is helpful.
Next is, does attending a conference or a workshop suffice to claim expertise in a technique in cases of negligence? Like, I may not be doing cardiac case, but if I'm attending workshop on pediatric or regional, can I claim if there is a case? Will it help me that I have been trained?
Yeah, attending a conference or workshop is just the beginning of acquiring expertise in a technique. But definitely it is not sufficient to claim expertise in a particular area solely because it is your attendance based. Hands-on training is also important. Continuous practice is important. Ongoing education to really develop the proficiency in your expertise. So you have to keep abreast with your regular trainings.
One more small question. How important are availability of various gadgets or monitors? Again, from the point of view of avoiding medical issues. Like we may or may not require them. Like with our long practice, sometimes people feel it's not necessary. But from the medical point of view, medical legal issues rather. How important
Particularly
are
my generation has gone through that transition. I know my senior colleagues, clinical based, at the tip of this thing, they used to see cyanosis, they used to manage. I myself has seen the trend. So definitely the availability of gadgets and monitors is crucial in avoiding medical legal issues. Modern technology and monitoring device do help an anesthesiologist, an intensivist, to diagnose very early, to respond quickly. You can avoid complications also, reduce the adverse effects and also legal implications. However, over reliance on this technology should be avoided. and a very sound clinical judgment. And the skills do remain an essential fork for this thing. They are really essential.
Thank you, sir. This question is for Dr. Asit Vaishnav. Is it mandatory to have OT technicians in OT?
No. No. It's not mandatory. It is not mandatory.
Similarly, is it mandatory to have anesthesia technicians in the OT?
For anesthesia technician, it is no. For OT technician, I can't comment.
Okay. And who is liable for equipment failure and drug reactions due to substandard drugs, especially in setups where you cannot command the procurement, like in government setup?
You have
the
to prove
procurement
it.
is done by somebody else.
Yes. That agency has to prove it that the thing was deficient. It is not in our control at all. It is not our control at all. If incidents happens like PGI, then the inquiry and drug controller and all, they can prove it. Otherwise, we do not have any access to that thing in our practice.
Will we be held responsible for using a certain drug?
Till then it is proved, we are held responsible. Till then it is proved, we are responsible.
This question is to Dr. Pratibha Kane, madam.
Yes.
Ma'am, are you there? Yeah. What are the mandatory equipment for providing anesthesia in a hospital? Like, actually, it's a big list. Could you just, from medical legal point of view,
See,
especially since
having
you
a
mentioned a case about not having a ventilator. That's why I'm asking you.
Yeah. See, most of the times what happens is when some things go wrong, people, kind of look to see, where the deficiency is. So if the ventilator, they have actually had a criminal case, right? So see, ventilators are the more critical patients that you take, the more monitoring you require. So there is no two ways about it. So any anesthesiologist who feels that there is, more than 3 comorbidities, IHD, having low ejection fraction, you have to decide whether you want to do these kind of cases or not. See, these cases which have come up, they are usually, even the judge can read that this is a high risk case.
Ma'am, somebody
So
was asking,
taking risks, the main thing, what the judges understand, see, medico-legally means I have just presented what has happened. So, in somebody's life, it may never, you can get away. But today, getting away may not, because there's so much of information available. So everybody can know about, everybody, especially post-COVID, knows about ventilators, So they know about ICUs, they know about ventilator. Before, it was not so common. But now with COVID, everybody, like, why wasn't there, ICU? Why was the patient not shifted? Why did you attempt it in the first place? These are questions which come when complications happen. So we should be able to, kind of give reasonable scientific answer. So, I just feel in today's day and age, doing laparoscopic surgeries without a ventilator and an ETCO2 is generally puts the patient at risk. Now, there are so many people doing it with a vein circuit. Even we used to do it, like when we started, we were doing all this. But today, things means accountability is more today than it was 10 years ago.
Madam, I would like to ask the one question that in ISA national guidelines, ventilator is not mentioned, I think so.
No, it is not.
So,
It is not.
it
But
is
a
not
boils
mentioned.
machine. No, a
Boils
boils
machine is
machine.
okay, but ventilator is not mentioned in ISA national guidelines. So, what is your take on
Workstation.
that?
No, see, like
ventilator.
I told you. Yeah. So when
They have
we
given
talk
option.
about
They
an
have given
anesthesia
option of a.
machine,
They have given the option of an anesthesia machine, boils machine, or a ventilator, means a workstation. But they have not given as a post-operative ventilator as a specific ventilatory care post-operative.
It is
So
not.
what is
It
your
is not there in. It is not there in the previous guidelines. Because I mean, like what we have actually, kind of know that the anesthesia, like what we did in COVID, the anesthesia ventilators can be used to tide over situations. Okay. You may not have a ICU, but one needs to know where to shift a patient in case prolonged ICU care is required. Okay, you cannot just kind of say that, because unexpected, see, medical uncertainty is a real problem even in ASA grade 1 patient. So when you start, I mean, when you are practicing, I feel, which blood bank will you, kind of, in case of emergency, everybody doesn't have blood bank on their premises, but where will you get it from? Or, ICU, where will I shift? Because it is very clear that the responsibility for transfer lies on the person who is transferring, till you actually go and somebody else takes over, because there's so many deaths happening during transfer. So one must know who is going to receive, the communication at that point. Is the patient safe to receive? So ventilator, definitely. ICU has not been said that you cannot, but we did have a case where the Supreme Court has said that do not take high risk cases if you don't have an ICU backup. And most important, I feel, is communication with the patient. Okay. There is a question in the chat box which says that, yeah, we feel that patient is high risk, but the patient says operate here only.
Yeah.
Okay.
Yes.
So now this problem does come. And let me tell you, everybody who says, we trust you, we believe you, and everything, the minute something goes wrong, they can turn, and there is no consent to be taken. But at the same time, if you can say that, okay, if a complication happens, we have to go here, or if I don't have blood bank here, but you have to get blood here. These kind of communications, if you can put them on your consent, because you need to operate and the patients do not have the resources, whatever it is, but a clear communication on that thing, even that can go wrong. I'm not saying it's a guarantee, but it will give you some kind of moral, standing that you did explain and you didn't want to do it. So that is my take, that, clear communication with the patient, that these are the limitations of this setup. In case anything happens, this is where we have to go, and we will accompany you, or something of that, sort.
Yeah,
One
ma'am,
more
shall I
question.
add to that? Now, talking about the ISA guidelines. ISA guidelines are basically to guide the anesthesiologist what should be done in anesthesiology. You can't have a ICU with every clinic of the country. A single city may have almost more than 250 hospitals. A good city, 250 hospitals. You can't have 250 ICUs. And why the Clinical Establishment Act was, blocked? Because they were saying ICU with every OT. And how many times, if you go by the cost effectiveness also, forgetting about other things, how many can really afford a ventilator which remains lying vacant for so many years and you are wasting money on the ventilator? The idea is to give the guidelines for anesthesiology pre-operatively, post-operatively. Madam is right about the shifting, where we should have a partnership with any ICU in the city, where we can always shift our patients safely. When you are taking a patient, the patient believe in you, you give them the best option that this hospital, we have got this facility, we are going to do operate for you, but these are the facilities and these are the limitations. But if required, we can shift you to if any complication come, we can always help you out in shifting to that. We have to be honest here to the patient.
Yes,
The next
and
part
the
is,
planning should be very clear in our heads also. That,
there should be a protocol.
we will.
Should be a protocol
Yeah.
of every case, because it doesn't matter. It's a high risk case. A single simple elective case can go critical during any surgery. So I think we should have a protocolized manner. We should have established our mottos how to do with an emergency if arises in that particular small clinic or a small multi-specialty hospital where we don't have the ICU. So anesthesia guidelines are basically for anesthesia purposes. The other are the critical care guidelines. Definitely ventilator will be mentioned there. So workstation, the boil machine, they will do the work same. Because when you are stuck in a case, you can maximum spend 6 hours to 10 hours. You can't spend the whole 24 hours with the patient. You have to take help of your colleagues and other associated ICU. That's what the meaning of the guidelines is.
Perfect, sir. I feel like we should go to the questions to the
So
speakers.
there's one question remaining. I wanted to ask Madam, what is the role of the anesthetist for post-operative care? This is important for us, like people who are running around from one place to another place. For how long should you wait the patient?
Okay.
Knowing that the
So
patient is safe.
this question, yeah, I know this question I keep answering. If the patient is going to be discharged, okay, you must put down objective guidelines. You can use the Aldrich score, and actually have an objective thing. Everywhere, if the patient is, kind of not come out of anesthesia, I think one should not leave. One should delegate the next case to somebody else. And not just that, I just feel that leaving a patient of spinal anesthesia and because the surgeon is late or whatever it is, the time management for freelancers is really very difficult. I have gone through it. And, keep peritoneum, we've closed the peritoneum, now let me go. We've had many cases where things have gone wrong. Patient just, kind of becomes hypoxic because they want to reopen or they want to just, look again, all kinds of things. So the responsibility is 100% ours, at least till the recovery room, till the patient actually, and especially in the private setup, the patient goes straight to the ward, right? And the patient's relatives can see that this patient is not awake, things like this. So you have to be a little careful how we shift outside. The patient has not talked, the patient has not moved. So it really, you just take the patient straight to their relative. And they are also now, everybody has become very, very sensitive. They will not accept, mediocre care. So having some person, they say qualified people in the ICU, you cannot wait afterwards. Have a Aldrich score if the patient is going to be discharged. If the patient is going to be in the thing, at least call up after some time. I always feel that even we don't check whether the patient's legs have moved or not. The spinal hematoma is definitely a problem, and it can really go wrong quite a lot of time, and delayed recovery from anesthesia, especially if we are using all these newer, I'm saying off-label drugs like Dexmed and stuff like that. They take our 6-8 hours. But is that because there is a spinal hematoma? Is it because so somewhere a call to you that, yeah, the patient has started moving leg. Everybody must have some person who will communicate with you, or you can communicate. I feel it is important.
Thank you, madam.
Ma'am, I just want to add here because there are so many experiences about these things. The anesthesia responsibility is not written in law, but I think for the first 24 hours, anything happening to the patient, you are equally responsible. No court will be leaving you for the first 24 hours. Because in institution circles, we always talk about the post-op rounds. We always talk about the awareness about anesthesia, awareness about the anesthesiologist. How will you get aware in the society till you don't do a pre-op round, a post-op round? You have to show that I was the person who administered you anesthesia and took you out. And the responsibilities lies solely with anesthesiologists. Here comes a little part of that question, which was asked to Vaishnav sir about having a OT technician or an anesthesia technician. I think in a practice, if one has a good technician with you who can take care of the patient post-operatively, something is little bit of, on the serious side, who can monitor the patient, who can help you out, you can always be very much relaxed Otherwise, you can't get the whole cases done if the list is 7, 8 patients ahead and you are getting some patient who is oversedated. But the person who is well managed, well oriented in managing the recovery phase, if that person is there to help you, that is the best person. This is my take on this type of thing.
And I will just open the screen to show these changes what are going to make.
Right. So if the panel discussion is done.
Dr. Dharmesh Gandhi is online. So we had to ask one question to him because he was a freelancer and now he's a proud hospital owner also. So what's your take on periodic raise of anesthesia charges? A third person's perspective. Dr. Dharmesh?
Well, actually, yeah, I'm there. Am I audible?
Yes, very much.
Yeah. That is the ideal thing which every anesthetist dream actually. But from a hospital point of view, I'm actually in both the sides. I'm an anesthetist also, I'm a hospital owner also. Day by day, it's going to get more and more difficult because insurance company are actually pinching the hospitals, and charges are very difficult to rise if you ask me. Because ultimately competition is rising. Everywhere consultants are rising, hospitals are rising, and the insurance companies are actually on the heads of the hospitals. So I think so it will be very, very difficult to give a hike every year of 10% to an anesthetist. That's my take. That's a very practical thing I'm talking.
So you certainly see a plateauing of our professional income after a certain age.
Yeah, definitely, yes. There is a plateauing of income, and given the scenario I had mentioned in my lecture, what BJP government is trying to, as a hospital, I know they are trying to get the CGHS rate to be implemented. The news was there in the newspaper of the Supreme Court has asked the government whether you are going to give a rate list to the hospitals or whether we should intervene. So it's very likely that this year is going to become a big problem, and we might get very less rates for everything. And as the anesthetist, we'll
No,
be the
Dr.
first
Dharmesh,
person
this has been
who will be
challenged.
problem.
This has been challenged. Don't worry. It has been challenged, and IM has taken it up. As far as possible, it may not be implemented, but let us see. It has been challenged. That I know.
That's a good thing, sir. Thank you.
Yeah.
So can we go to some audience questions?
Dr. Shakil is around. Dr. Shakil Momin. He was to be asked about his views on RVG.
Yeah, I'm here.
Sir, we would appreciate a very brief answer, but a 35 years old freelancer's perspective that how he should be implementing RVG in his own private practice.
Actually, this was discussed in 1992 in Kolhapur city. There is some other noise is coming. I don't know. Somebody has unmute. Somebody is talking and
Kane madam, your voice mobile is on or something.
Yeah. No, I think fine. There were 2 devices on in one.
Yeah. Please, sir. Dr. Shakil,
I am unmuted. Okay, somebody unmuted me also. Anyway, actually, this is the best kind of system. RVG system is the best, but you need not disclose it to, or you need not send it to each and every hospital. This should be discussed amongst yourself. There are 2 parts in the RVG system. The points for that particular case, depending on the nature of surgery, duration of surgery, risk involved, and the skill implemented. The points are given for that particular surgery, and there is a multiplying factor depending on the person's perspective. Means it differs from in city to city, even it differs from hospital to hospital. It differs from whether the patient is paying patient, not less paying patient, or a scheme patient. So that factor is different, and the points allotted for particular surgery are different. So everywhere in India, the points allotted for particular surgery must be fixed. They can, the ISA can give guidelines to say appendectomy of a 30-minute duration should have 10 points, and the multiplying factor for me it may be 1,000 rupees, so I can charge 10,000 rupees. If for somebody it may be 100 rupees, he can charge 1,000 rupees or something like that. So for ISA should give like guideline regarding this, and everybody should decide his own multiplying factor depending on again the payment capacity of that particular place where he is working. RVG system is definitely good.
So, sir, what we will do, let
Yeah.
this all the zonal discussions get over.
Yeah.
We will
And then-
imbibe all the suggestions here because RVG is not that simple to implement
Yeah, it
pan
is not simple.
India.
It is complicated.
So what
yeah.
we will do after imbibing all the discussion, will definitely come out certain concrete things where we can give our recommendations to all the practitioner associations also throughout the country. I think that
Yes.
will be easier after the
Yes,
after 6 months, I think.
Definitely, that is good.
Definitely.
And
Definitely.
one important thing about charges I want to say is we should not miss my thinking about this is the charges should be decided by me. The decision making factor should be with the anesthesiologist, not with the surgeon, hospital owners, or government now which is coming up, or not even to the Society of Anesthesiologists, ISA. ISA is not ISA can give guidelines.
Recommendation only. Recommendation.
Yeah, recommendation, exactly. My
Recommendation.
charges, I should be able to decide. So what we should insist is decision-making power regarding the charges, regarding the type of anesthesia. For both these, the decision-making power should be with the anesthesiologist. Thank you.
Anesthesia charges should be irrespective of surgeon's charges. This is a bold slide of mine in all my presentations.
We must try for decision making in these two aspects: the technique of anesthesia and the charges for anesthesia.
Yeah, Dr. Mugil.
Dr. Mukesh and Dr. Shivani, are you still there? Any questions for the
Dr. Tejveer,
speakers?
Dr. Tejveer is around. Dr.
Yes,
Tejveer is around.
Tejveer is there.
Dr. Bala Venkat has suggested some. He had asked some questions. Are you ready with those questions? Dr. Bala Venkat, sir.
He is not there, I think.
Okay.
Regarding one thing, I was, sir, with due permission, well, the financial planning of by the anesthesiologist, I think we talk about so many things: the fixed planning, the fixed deposit, the mutual fund, the equity, and so many things about the financial planning. That discussion keeps on going in the WhatsApp group. I think whatever we decide, one thing we should not forget: the best asset is your health. Whenever we go for any planning, the health is the foremost thing, because what's happened in the busy life of a practitioner, they don't have a fixed time that they have to do, they can do workout at this particular morning or evening, or I think that habit of getting a workout done any time of the day is very, very important for all the anesthesiologists, because once you cross 45 to 50, the body dips suddenly and all our financial planning goes to dustbin if our health is not with us. Our health is the best friend. Then comes the financial assets and whatever things we are getting. Because in the primary time when we are running our show, we are going about the cases. This case should not go from my hand. That case I have to take. This many cases I have to do in a month. This is my target. We should not lose our health at any cost, at any stage. Because your family needs more you than the money you have owed. So I think the financial planning and the health planning should go side by side, not sacrificing each other.
Good suggestion, sir. Yes, sir. Very good statement, sir.
Yeah, there was one question regarding the changing. Some anesthetists are not changing while entering the operation theater or while doing the procedures.
Yes,
So, what is the medical legal aspect of this? It's a very, very common practice, especially even in metro cities, in Mumbai, and I'm sure it is a common practice in other cities also.
Yeah,
What
that
was
was
the
put up
question?
by Bala Venkat, sir.
Yeah,
Is it
the anesthetists
mandatory to
don't change. Anesthetists don't change. They just walk in
while
with their
entering the OT
dress.
Yes,
in
sir.
OT dress.
Sir, I think this is a protocol which has to be created by the hospital owner, not just the anesthesiologist. Because if you say anesthesiologist is not changing, I'm definitely saying 99% of cases surgeon is also not changing in that case. The technician may not be changing, the staff may not be, they're just wearing the gowns. I think the protocols have to be set by the hospital owner, whether it's anesthesiologist or surgeon. Once those are set, everything can be in a line.
Yes, we follow the
Yes, sir,
protocols which the hospitals are giving.
Yes, sir. Even
personally, I feel one must change because the infection process is bilateral. Transmission of infection is bilateral. You can also carry infection to your home also and loved ones also.
Nowadays, all anesthetists are carrying their own changes in Mumbai.
Yes.
Yes.
Do we have any more questions, or I feel the two moderators have already left? I think.
If central oxygen is not available, is it the responsibility of the anesthetist to check the cylinders?
It is.
Yes,
So
yes. It is anesthetist duty to check the cylinders. Availability of oxygen cylinders till is patient the surgery ends and postoperatively. So the availability of oxygen cylinders in hospital has to be checked by anesthetist, inquired by anesthetist.
Sir, we are the lifesavers. We are the lifesavers. Everything associated with a life-saving procedure is the responsibility of anesthesiology, whether in an institution or in a private practice.
Yeah, one thing. Excuse me. One good thing about private practice is we are not dependent on our assistant.
Yeah.
we are checking ourselves. So this is one of the best thing for the private practice. The full timers, they may be dependent on their assistants for oxygen availability and all that. We are not. So that is a good thing. We are not dependent.
No, that's what I'm saying. Life saving, whatever the equipment is there in practice, you cannot depend upon anyone. You have to do your own work.
I guess that sums up all the questions, I believe.
Yeah, most of them, sir.
Yeah.
By any chance, do we have any of the GC members online? Dr. Manisha Katikar, Dr. Indrani.
Let's see, Dr. Vrinder Sharma was there or not?
He left. Mother was not well actually. So is he still there?
Because the maximum number was 192. Now it is 73.
Sir,
participants.
Everybody is being
from
left for the dinner,
192 to 73.
Hungry, I think they are.
Yeah, probably.
We are quite.
Is this the most prolonged webinar?
Momin sir.
Yes.
Just one more point, because there was a question about that time I could not answer about the workshops and CMEs. They were saying that the practitioners, whether they should be attending the workshop and CMEs, is it going to change their practice? Is it going to change their decision making? Is it going to be helping them at any stage?
It is.
The answer was good. No, Dr. Brito answered very beautifully. My take on that question is that workshop and CMEs are not meant to train you permanently. They are there to make you aware that this thing should not be done. You cannot have a learning curve is there. Learning curve is definitely there. You are out of touch with the academics and the newer developments. So when you attend a workshop and CME, definitely the message goes to every anesthesiologist, whether practicing in the peripheries or in the institution, that this is the newer development, this is the new way, this is a new technique. It should be done like that. If you cannot do that, then you should not do it in your peripheries or even in the institution. So I think attending a workshop and CME will make you a wiser person. But in the long run, you can always have hands on it. You can always do something under guidance or under cautiously before proceeding to make it imbibe in your own practice armamentarium. That was the
Dr. Ravindra Bhaskar is online, I believe. Dr. Ravindra Bhaskar, Dr. Chaubey, our GC members, are they there?
Dr. Mohan Pathak. Dr. Mohan Pathak wants to say something.
Raised his hands.
Yeah, he had raised his
please,
hand.
definitely. Anyone can make any comments. Just raise your hands. We will give you permission. Dr. Mohan Pathak, please unmute yourself.
Hello.
Can you hear me? Sir.
Yes, sir. Yes, sir. We can hear you, sir.
Can you hear me?
Yes, please go ahead, sir.
In case of cesarean section was done for fetal distress. Hello.
Yes.
You go on.
Sir, go ahead, please.
Yes, Dr. Mohan, please, we can hear you properly.
Sir, you are muted now, Dr. Mohan, sir. Unmute. Now you ask whatever you want to ask.
Yes. So cesarean section was done for fetal distress. With patient, there was no problem, but baby developed palsy later on, and the case was filed, where anesthetist was also held this in the name of the participant, or he was also blamed. So what are the chances? There was no problem with the mother. She had again cesarean section. The next babies were normal, but this baby had a cerebral palsy because of fetal distress. So what are the chances the anesthetist will be issued or he will be penalized?
Sir,
Hello?
shall I take this answer?
Yeah, please, sir.
Been practicing the obstetric anesthesia for a long time now.
Yeah.
Sir, see, in any hospital, whether you are working in a peripheral or in an institution, whenever section is done, it's ideally the pediatrician should be available right from the time a call is made that the patient is going to land up in a cesarean section. All the arrangements for a child has to be done by the pediatrician. Anesthesiologists are just the second line. If any emergency arises, they are there to help, not to take primary care of the pediatric patient. Now, in this cesarean section, if you think that the patient's cerebral palsy is the result of the anesthesia, which is very difficult to prove in a court of law, your record which should be there, whether the patient had any hypotension, any placental perfusion chances are there, non-perfusion chances are there during the section. So you have to have a documentation of your this one right from the induction of anesthesia till the delivery of the baby. When your record is good, I don't think so there are chances that anesthesia will be incriminated for that. Moreover, if you have used the GA or the drugs which have caused sedation or which may have, but which is almost impossible to prove. That child with a cerebral palsy, many times it's maybe having in the congenital phase or maybe having the ultrasound report also has to be there, which may not also prove very conclusive. But chances of anesthesiologist getting incriminated as a part of team and solely because of anesthesia are very, very remote. It's because of it has to be proved that a child suffered because of the drugs associated with the anesthesia, whether it's GA or spinal, where the hemodynamics are compromised.
Or mother developed cardiac arrest and consequence of that.
Sir, that's why hemodynamics has to be there. Hemodynamics and
that has to be proved. That has to be proved.
Dr.
There was
Tendulkar,
no
Dr.
problem
Pankaj.
with mother.
Dr.
Yeah.
Devadia sir wants to
Can I
come
come
in.
in?
Dr. Devadia, hello, Dr. Devadia sir wants to come in.
Devadia sir, please.
Yeah, good evening.
Good evening, sir.
So, I just have 2 points to make over here at this point, at this stage. One is, you cannot prevent anyone from suing the anesthetist. It may be justified, unjustified, it may be right, wrong, based on fact, based on fiction, based on someone's perception, what some mama or ward boy or ayabai in the OT has told them. So you have to be prepared to be sued at any time, whether you've done the right thing or not done the right thing. What will save you is appropriate documentation, correct documentation, and that you followed the proper medical protocol or medical procedures, or you've done what you're supposed to have done, and that sort of thing. I think so. Your defense has got to be that you've done the right thing and you've documented that you've done the right thing. After that, you are at the mercy of your lawyer, the opponent's lawyer, and your judge. Okay, or who is a member of the consumer forum. And we know that some of the decisions given in some of these fora are quite silly and stupid and irrational as far as we are concerned. But the fact remains that these things do happen. So, but like Dr. Kane was saying, the bottom line has to be, you have to be, your documentation has to be perfect. The other point I wanted to make, I don't know, I was lost in the middle for some time. When you were talking of financial stability, security, and so on, I just to take this opportunity to say that please become members of the ISA FBF if you are not members, Family Benevolent Fund, and please encourage all your colleagues and friends to become members of the ISA FBF. Every now and then we say, "Arey, poor fellow, he died so young," or this happened and that happened. But this is the one concrete way we can contribute to supporting the family of one of our colleagues who tragically passes away. And the problem is, when people are young, they don't think that they're going to pass away, and no one thinks they're going to pass away. But if some tragedy happens, then that is the time when they've not done any financial planning, and that's the time the family is most vulnerable if they're not very well off to start with. So this is one concrete way we should all do this. And again, I will appeal to all of you to become members and encourage all your colleagues, friends, people in your city branches and so on to become members.
Perfect, sir. Perfectly said.
Thank you, sir. Thank you.
Very
Dr.
important
Virendra
for
Sharma has
everybody.
joined.
Yes.
Dr. Sharma has joined.
Please unmute yourself. Virendra.
Hello.
Unmute yourself. Unmute. You are muted.
Okay, thank you, Dr. Pankaj. Good evening to all. First of all, I was never expecting that it is going to continue for 3.5 hours. I was having some problems at my house. My mother was not well, but somehow because Dr. Pankaj told me that this will be the first one, so you please try to attend, and I attended from 6 o'clock. But then it is the first of its kind, and now that it will be regular. So first of all, big congratulations and appreciation to ISA National that this kind of a thing is started. My suggestions are that since we are going to do it every month, so because we all know the problems of freelancers, I appreciate that so many have remained for 3.5 hours. Our maximum attendance reached around 200, but definitely we cannot expect our freelance anesthesiologists to continue to attend webinar on a working day for 3.5 hours. But since it was first of its kind, so from next time, Dr. Pankaj, my request would be to limit it to 1.5 hours, so that our majority, because see, this discussion is very important. Let me tell you. See, the lectures we can have in subsequent webinars, but the most important thing is the queries of the members and the answers by the experts or our office bearers. Many members may be having certain things in their mind. They want to speak about what ISA should do for them, what they expect from ISA. And see, our secretary and president, they are still here. That shows their commitment. That for 3.5 hours they are there.
Appreciate it. Yeah,
so it
really appreciate
is our duty that from in future, we try to limit it to 1.5 hours and at least give 45 minutes. Only 3 talks, 45 minutes, because it's a monthly affair now. And 45 minutes to members. It's a rare opportunity to interact with your ISA president. See, our ISA society is now having more than 45,000 members. So it's a very good opportunity for practitioners to interact directly with the president and the secretary. And we must utilize it. That is number one. Number two is, after hearing all this, I have a few things in concern which we all have to keep in mind. That look, things are going to become more difficult in future. Let us accept the fact the government is doing their best to increase the number of anesthetists like anything. Forget the number of MD seats increased. I'm in Lucknow. There used to be only 12 seats of MD in KGMC. Now it is 38 per year. In Safdarjung, it is 72. In BGMC Ahmedabad, it is 68. And apart from MD, the DNB has come up with diploma. And that diploma in UP, every medical college, Basti, Ayodhya, Baraj, whatever is started with DNB diploma, only with a 5 year of experience, with no teaching experience required. So that means they are going to increase the strength of the anesthetists like anything. The only solution for us is that we must keep united. Every city branch must meet regularly, if not regularly physically, at least make your WhatsApp group. Try to engage your juniors. Let them not be exposed to like anything. Then we blame them that you are doing cases. Since like Dr. Pankaj said, we are from beginning, we are in almost every city and state. There was an incident in Bhopal and people started criticizing that poor fellow. Then later on wrote that nobody informed me that there is such a thing in Bhopal. There is some minimum anesthesia charges. So it is our moral duty to involve them. Let them be informed that yes, this is what we have decided. Please try to follow. But if they do not know, we do not involve them, then why should we blame them? Times are going to be tough, but the commitment shown by the ISA National, I must appreciate. Now it is the responsibility of the practitioners to get united and interact and do the best whatever they can do for their colleagues. Thank you so much to everyone. Thank you, Dr. Pankaj.
Thank you, Virendra. Nice of you to come.
I think Rakesh is also there. Dr. Rakesh.
Rakesh is there, yeah.
Dr. Chauba is there.
Yes, sir.
Dr. Rakesh.
Yes, sir.
खाना तो नहीं
I think
Just finished, sir. So excellent discussion. I think many good points has come up. As I mentioned earlier, also there has been a huge government support also for various public-private partnerships. So I think that also needs to be looked for various programs which are coming up. And as Dr. Bajwa, you rightly mentioned also that there has to be some collaboration between different units because some centers may not have super specialty or support for certain aspects. So if we have good collaboration of transfer from one hospital to other hospital, I think that will give a big leverage from the medical legal point of view. And this has started very recently in Delhi. Initiative has been taken by the government where the inter-hospital transfer policy is being started. So any patient who is being transferred from one hospital to other, they will have something like an MOU. I think this process will more empower the freelancers and private practitioners to take the things forward. Very good discussion. In fact, I learned a lot. So thank you, everybody.
Thank you, sir. I invite Dr. Pankaj to make the concluding remarks and conclude the webinar.
I feel it was a fantastic discussion. I had expected it to last for around 2.5 hours. And as you said, we were around 200, and I feel even now we are about 60, 70 odd people. Even though it's almost 9:30, I feel I should really thank National ISA, and it's very great that Dr. Bajwa and Dr. Diwati sir are still with us. Dr. Rakesh has always been a dear. He's always around for all good activities. It was good that Virendra sir should come sometime. His mother is not well, I know that. I feel all the panelists were excellent. The speakers were excellent. And we had a very, very good beginning. I mean, I could not have asked for more. Dil mange more ye hai. 28th May, we will organize for the South Zone. Maybe for the first 5 months, we will continue in this way. And then maybe after that, every month we can have dedicated specific more of discussion talks rather than this. And of course, as Virendra said, rather than 6, maybe we'll have 3 or 4 talks. Let us see how it goes. But thanks a lot. I mean, I'm sure Dr. Bajwa would like to give the concluding remarks.
Yeah, Dr. Pankaj, the most important part is after this webinar ends, it will be available on YouTube. What I advise is you just go through that recording, note down the gist of this webinar, important suggestion, so that when we prepare a draft for implementation in our maybe after 6 months to 8 months, we should have the points because many points are there which have been discussed will be forgotten, will not be taken care of. So record it and just pen it down. So and make a gist of it and send to me so that at least we will have a record so that whenever in the future we're going to make some recommendation, those points should, because excellent points were there. They come in breakups. Everybody cannot give all the points. So it has come in a breakup manner, but we have to imbibe those points in our recommendation, in our guidelines also, in our advisories also. So to make the functioning of peripheral anesthesiology a better place for in India. And I think Dr. Diwati sir is raising.
Yes. President sir.
Yes.
Yes, sir. I just wanted to say, Pankaj, excellent start. Very good, this thing. But, there is a very important saying. It says less is more. So, while 3.5 hours is good, maybe 1.5 hours, like Dr. Virendra said, would be better, right? So let's try and limit it because attention span of everyone is also limited. But this was a fantastic beginning. The only other point, Dr. Bajwa was saying about summarizing everything. I don't know, but in the new version of Zoom, there is an artificial intelligence icon, an AI icon, which actually summarizes the whole discussion. So maybe you have a look at that and see if it sort of suits what you've done. Otherwise, the old way is always there. You go through the whole recording and you sum up whatever is there.
Please guide me, sir. Please guide me about this AI.
But very important that we summarize this discussion and note down what are the problems, what are the potential solutions, and what solutions people have already found and how they are working. Others can decide whether they can use a similar solutions or not. But I think that's very important. And when we work across zones, we will have that, we'll have the full idea. We'll have the whole overview, bird's eye view of what's happening across the country in freelance practice.
Sir, actually what happens when I tried to use that artificial intelligence in the Zoom, the only problem is because the accent of the people are different, the pronunciations are different. So when it summarizes, when it, it translates into the written matter, things go so clumsy that in correcting them, you waste so much time.
Yeah.
That's
So I mean,
only...
that's why I said try it out, see what happens. Otherwise,
I tried 4-5 times.
Okay.
Everything, but it was not working because I think whatever the accent we are using at a different regions, that is not covered with Zoom even. So we get some different meanings of whatever was said at that time, and it becomes so double work. It becomes a double work for any interpreter to go with the exact meaning of what was said and what is being published there by the artificial intelligence monitor.
Okay.
Nice, sir. What Diwatiya sir is suggesting is a very good idea. When you are talking, I was just looking at it, and the meeting is about this. The AI companion says the meeting is about discussing the implementation of artificial intelligence in the freelance practice across the country. Dr. J.V. Diwatiya is speaking, and I mean, it's actually understanding what I feel we'll have to study it more. I mean, someone who really tech savvy should really look into it. It is giving, so probably this AI companion should have been switched on every few minutes. What I'm trying to understand from this, it was giving a gist of what, like just what we were discussing.
Dr. Pankaj, that's what I'm saying.
Given in a gist.
That's Pankaj, what I was saying. I have turned it on many meetings. It is not giving the good results. You know, you have to use the real intelligence over the artificial intelligence sometimes. That's what I'm saying. I'm using Zoom for the 1 year because artificial intelligence came 6 months back as a partner of a Zoom.
Right.
It will take some more time. It will require some more time.
I think,
Dr. Tendulkar.
Yeah, most welcome, sir. Most welcome.
And I think Dr. Ganesh Tendulkar and Dr. Tejveer Singh will be given the opportunities to host many other events also, not just private practitioner forum, because it's the way of questioning the thing, the way of moderating the session that's more important. And I think we have got many good leaders to lead this type of academic and non-academic discussion. So definitely we will have we will sort out these names also in the future. We may require your services at many places, sir. So that will also be done. And senior people, Dr. Ashit Vaishnav sir, and all those people, I agree that we have to limit our time now. Next time, I think, sir, maximum we should go for 2 hours, maximum 2 hours, because that's a period, definitely attention span and the family time is also there. The whole day goes in meeting. It's very difficult to spend all the 3.5 to 4 hours on the monitor. Although we are used to it because our GC meeting go beyond that, even 8 to 9 hours also, but not every day. So not every month also, because we have got academic and non-academic events both going simultaneously. But it was definitely a very good beginning, and I think we will always, ISN National will always be behind this forum, and we will definitely come out with more healthy guidelines in the future, and more. I think already we are under the process of revising, which were formulated much earlier, almost 8-9 years back. So we are in almost finalizing it, and we will be coming out with a booklet this time. Those will be the booklets will be published and they will be distributed accordingly to the, we will see how much cost is there for the booklet. So we will be distributing it to all the members who will be requiring it. That will be done. So, Dr. Pankaj, shall we conclude here? Diwatiya sir,
yes,
permission?
Please, please.
Yes,
please.
sir. Yes, sir. Thank you so much, sir.
Just imagine it was 8 o'clock and not 9:45.
Yeah, sure. Next time, 8 o'clock. So I think we always end the session by saying long live ISN.
Long live